blood purification, and organ support in critically ill patients in relation to COVID-19. And second, the role of hemoperfusion, when to start, earlier the better, and not a rescue therapy, and when to add other organ support systems like CRRT or ECMO. We will discuss cytosorb, oxalis, and polymyxin B, and this will be discussed by Professor Yatin Mehta and Professor Molnar. And finally, the role of extracorporeal membrane oxygenation for acute lung support, and Dr. Vivek Gupta will be discussing in this topic. So to discuss all these aspects, we have a very distinguished faculty in Professor Vinay Sakuja, my teacher and mentor, my dear friends, Professor Kohli, with whom I had a training on CRRT with Professor Ravinder Mehta at San Diego way back in 2002. And my dear friends, Dr. Umesh Khanna, Dr. Manisha Sahai, Dr. Mukherjee, Dr. Rajesh Chawla, and my younger friends, Dr. Prachi, Dr. Tanmay, and Dr. Zakaria. So who will be chairing and moderating this discussion and share their experiences. And over to Seema for introduction of chairpersons for the first talk by Professor Molnar. Seema, please.
Thank you, sir. So we start with the first session, which is on the topic of role of cytokine in human sepsis. And it's with great pleasure we welcome our chairpersons, Dr. N. Gopalakrishnan, Director, Institute of Nephrology, Madras Medical College, Chennai, and Dr. Umesh Khanna, sir, Director, Kidney Associate Consultant, Nephrologist, Asian Heart Institute, Karuna Hospital and Suchak Hospital, Mumbai. I request Dr. Umesh Khanna, sir, to kindly introduce the speaker for this session.
Dr. Umesh Khanna, kindly introduce.
Yeah, I think I did not unmute myself. So good evening, friends. It's my proud privilege to be a chairperson for this important session on the role of cytokines in septic shock. And truly and genuinely, cytokines have taken the whole world in a storm, actually. And the importance of it was always known, but with the advent of COVID, it has really become more important. So we have an eminent speaker, Dr. Molnar, to deliver his talk on the role of cytokines in septic shock. Dr. Molnar is the head of Department of Anesthesiology and Intensive Care Medicine at the University of Szeged, Hungary, and has done phenomenal work in this field. So over to Dr. Molnar to initiate the talk, and we will take the questions at the end. Dr. Molnar, please.
Yes, dear Dr. Khanna, dear organizers, dear friends, it is really a privilege to be invited to this meeting, to this conference, and I am really missing all those travelings to India that I have been doing for several years now, several times a year. And I do hope that sooner or later we will see each other again in person. So I hope you can hear me and you can see my slides.
Yes.
Dr. Khanna, is that okay? Everything is perfect?
Yes.
Perfect, perfect. We are able to see you as well as the slides and hear you all.
Thank you very much.
Right.
So a very warm greetings to all of you. Behind me is a very nice picture of one of the most spectacular capitals of Europe. It is Budapest, Hungary. In fact, I'm not working in Szeged anymore, but at the University of Pécs and also in Poznan. And but nevertheless, I'm still involved with critical care and anesthesiology, which is my main profession. And these are my disclosures, and you can see that I'm a medical director for cytosorbent Europe as well as I have other disclosures. Going back to the main topic of cytokines, this gentleman is Professor János in Hungarian, but Hans in German, so Professor Scheje. And he was born in Hungary, but then performed his research in Montreal, Canada, for the rest of his life. And this is a paper, very important for all of us, published in 1936 in Nature. And he was experimenting these rats. And what he did was that he exposed the rats to acute non-specific injuries, several, burn, trauma, whatever. And what he discovered was that there was a typical syndrome that appeared after the injury, after a certain period of time. And this was independent of the nature of the damaging agent. And it was rather a response to the damage. You know what it was? This was the discovery of stress. So this is how Professor Scheje discovered stress. And he was nominated for a Nobel Prize, never got it. And then he was nominated for 16 times later for other reasons for Nobel Prize, never got any of them. But his intuition and his discoveries linger on. And this is how we got to this discovery. Then this was when we discovered that damage and pathogen-associated insults are extremely similar even on the molecular level. What does DAMP mean? DAMP means damage-associated molecular patterns. This will be produced after any type of insult to the cells, when the cellular structure itself is damaged. Surgery, trauma, pancreatitis, in other words, sterile inflammation, ischemia, reperfusion, whatever. And the striking discovery was that just as in Scheje's experiment, the animals responded the same way, regardless whether it was heat, trauma, surgery, whatever, we respond the same way, regardless whether it is damage or pathogen-associated insult. PAMP means pathogen-associated molecular patterns. And the striking discovery is this, that the cytokines, the released molecules are almost the same or exactly the same, regardless whether it is DAMP or PAMP. Now, this is not just a privilege for the critically ill. You and me, in front of the screens or on in the audience, we all suffer PAMPs and DAMPs daily. Like, look at this. This boxer's face and this knee after knee replacement surgery, they will show the local signs of inflammation tomorrow. They will be swollen, tender, hot, red, showing all the signs. But both the boxer and this woman will return to normal life after a few days, no problems whatsoever. And we do suffer infections, local infections or systemic infections like a flu, regularly. But after a few days, this child will heal without any medical help. So we can recover from these insults. Why? Because we produce cytokines. So a very important message is that cytokines are essential to conquer injuries, any type of injury. So these are not evil cytokines. This is a necessity, a must to overcome these problems. But this can only help us if we are healthy. So what does it mean to be healthy? This is a recent paper in which we summarize this philosophy. And for me, health means a balance between the antagonistic forces. And this is what yin-yang depicts. This is a balance between the antagonistic forces. And just think about homeostasis. It is a balance between acid and base. Two antagonistic forces, but they must be in balance for your homeostasis, your pH to work properly and to be alive. The same holds true for pro and anticoagulation. These are not enemies. These are two equally important but antagonistic forces, but they must be in balance to prevent you from deep venous thrombosis, stroke, but also stop the bleeding when you cut your finger. Oxidants, antioxidants, the same story. We need both. It's not like antioxidants are good and oxidants are bad. No, we need both, but they must be in balance. And from this whole story of sepsis, this is the most important. the pro and anti-inflammatory forces and their balance. This is a very nice paper, and you know Didier Payen. He was in India several times and gave lectures on critical care conferences. And this is a very important paper. I quote that every time. What you can see on this figure is that we have the immune system with two main components, the innate and the adaptive immune system. Let's call these the pro and the anti-inflammatory forces. And what you can see here, that these forces function on a baseline level when you are healthy. But when you are ill, the immune system, or you injure yourself, it doesn't matter, your immune system changes gear, increases its activity. But it's not only the pro, but also the anti-inflammation. The role of pro-inflammation is to kill the invaders, to get rid of the dead tissue, to save you from all the debris and the toxic materials. The role of the adaptive immune system, the anti-inflammation, is to keep this war under control. And if you are healthy, after a few days, you will recover. And the first problem is here, that in our patients who are critically ill, this nicely tuned balance goes out of hand, out of order, and pro-inflammation overwhelms anti-inflammation. In other words, the body becomes its own enemy. Our immune system becomes our own enemy, and these patients can die early due to septic shock or to hyperinflammatory shock. This is why the systemic inflammatory response syndrome, something invented in 1991, published in 1992, was a wrong concept because it labeled normal responses as pathologic. Nevertheless, hopefully now we have the sepsis 3. This is Mervyn Zinger, the first author of the paper. And now we define sepsis as organ dysfunction due to dysregulated host response. So let's go back to this figure, the balance between pro and anti-inflammation. If our patients survive the initial hyperinflammatory period, they can go into a late phase that is called immunosuppression, immunoparalysis. And these patients are very prone to multi-drug resistant strain infections. These patients are extremely sensitive, and we have to take special care for them. So if you interfere with the inflammatory system, it is a double-edged sword. If you do it early, when you time your anti-inflammatory therapy, it may be helpful. But if you time it late, you may do harm. So let's go back to the initial phase of sepsis. This is the Jennings study, and the picture here is of John Kellum. His group performed the Jennings study and from Pittsburgh, the United States. And what they found was in a large cohort of patients with pneumogenic sepsis, that patients who had high pro and anti-inflammatory markers, they had a higher percentage mortality. And when they looked at the hazard ratio, accordingly, the higher the rate of inflammatory mediators, both pro and anti-inflammatory, the higher the risk of dying. So it follows simple logic that therefore, if you can reduce the level of these cytokines, you may reduce the hazard ratio, and it may reduce the chance of dying. So blocking or reducing cytokines may be beneficial. So we've been searching for the magic bullet for several decades. And we were one of those. We were very interested in antioxidants, especially N-acetylcysteine in the late 1990s. And we published several articles. But at the end of the day, when we completed all this process, and this was this German sepsis guideline in 2010, which said it is not recommended to use antioxidants, especially N-acetylcysteine, and one of the quoted articles was ours. So what we learned, that there is no magic bullet. However, when you read the COVID literature, just recently it was published that N-acetylcysteine is it's a useful drug against COVID-19. Well, I strongly disagree with this medical hypothesis article, so I do warn you. There are more than 52,000 articles published within 6 months, unprecedented in medical history. Be very careful what you read and be very, very critical. So let's go back to science, okay? So there are a lot of studies that were published over the last decades. And this is a review, a meta-analysis from 2002, almost 20 years ago, in which they evaluated a lot of studies aiming to antagonize cytokines. And what they found was very interesting. What they found that the higher the chance for the patients to die, there's a linear and significant relationship. So the sicker the patient, the higher the chance they will benefit from anti-inflammatory therapy, let it be animal or human experiment. So the sickest may benefit the most, but the healthy may suffer harm. And there was an editorial published for this paper, does blocking cytokine in sepsis work? And they said that in the low risk of dying patients, if you block exogenously administered cytokines, then it may interfere with the intrinsic benefit of cytokines. We need cytokines. So if you do it in an uncontrolled manner, you may do harm. Now, when you read the Surviving Sepsis Campaign guidelines, then you know that there were several of them now, 4 in fact, and you will not find one single word on anti-cytokine therapies, despite all the arrays and a large number of studies published. So they quote that, however, they do believe that these trials should not be abandoned and we need antisepsis therapies. Now, that was in 2002. However, since then, fortunately, we have a change in paradigm. We have to appreciate that there is no antisepsis tablet and there will never be one. You don't treat sepsis, but you treat organ dysfunction, respiratory failure, hemodynamic instability, renal failure, whatever. And then if there is infection, you treat the infection, the pathogen-associated molecular pathogens. So there are new terminologies as well. Instead of just sepsis, we have now dysregulated host immune response, fantastic, cytokine storm, hyperinflammation. And these are meant to replace SIRS, much more scientifically sound and more coherent to our current knowledge than just SIRS. And we also have a term, vasoplegic shock, which is to replace septic shock, because it was very silly to call a patient with acute pancreatitis in a massive vasoplegic shock, septic shock. There is no pathogen. It is not sepsis. There are no bacteria. It is a damage-associated molecular patterns-based vasoplegic shock. And of course, the rationale to remove those produced cytokines in abundance does make sense. Now, I very often receive this question that, okay, but removal of everything, it doesn't make sense. It does. This is a paper we recently published, and in this you will find these figures. Let's take 2 fish tanks, one with white fish, one with blue fish. Mix them in a 50-50 ratio. And when you merge your net, it follows simple logic that most likely you will catch 50-50% of both fish. However, if you take a lot of white fish and just a few blue fish, again, it follows simple logic that if you merge your net, you will catch a lot of white fish and just a few blue, if any. So this is the rationale of removing the overly produced cytokines and leave the others rest in peace. So we will talk about this later, but now just a few concluding slides on this issue. This is a very nice paper on COVID-19, the trinity of COVID-19. And just the conclusion of the article. It's a very nice physiological summary. And they say that removing PAMPs and DAMPs is very important in COVID and in other conditions. In fact, controlling the inflammatory response may be as important as targeting the virus. Some authors from the Netherlands go as far as they say that because septic shock originates from severe host response, then these patients may benefit more from hemoadsorption therapy than antibiotics alone. And we are talking about septic shock. A very provocative statement. And this is how we, my good friend Jan Bakker, who is the editor-in-chief of the Journal of Critical Care, in this editorial we both wrote, we summarized the whole thing, that there is an injury, regardless whether it is damage or pathogen, there is a host response. And some patients will get critically ill. And you can stabilize these patients, fortunately, in large numbers, and they will recover. There are those who will develop hyperinflammation. And then there will be those patients in whom you cannot help. And there will be those who you stabilize again and they will recover. And this is the gray zone. Those who develop this cytokine storm and your conventional measures do not seem to work, in whom you can consider, and possibly you should consider, some adjuvant therapies to modulate the immune response. So more on this in a bit of time. And this is my last slide, from which I rephrased from the Bhagavad Gita. I learned a lot from Bhagavad Gita, and this I've been quoting. Of course, I adapted this. And this is when Arjuna is with Krishna on the battlefield. That's the beginning of the book. And what Arjuna learned from Krishna, I learned a lot from this conversation and translated it to the bedside. And I keep saying this to my junior doctors. It doesn't matter whether you've done the right thing, but whether you've done everything to do the right thing. So if you do know that there is hyperinflammation, there are tools to conquer this, but you ignore it, you possibly haven't done everything for your patient. Thank you very much for your attention.
Thank you, Dr. Molnar. Thank you so much from taking us from the simple explanation of how cytokines help in localizing infection, to the newer terminologies, to the DAMPs and the PAMPs, and then the yin-yang of pro and anti-inflammatory, and how regulation is important, and how dysregulation came up as a term to explain the exaggerated host immune response. You took us through the cycle of how cytokines from a friend becomes a foe, and eventually how there are newer therapies, or at least a change and shift in the paradigm as to how to handle cytokines, whether removal of cytokines really is going to be a paradigm shift in the treatment, whether it will deliver what it promises to be. And we all know that there are a lot of therapies which we are looking forward to in the form of blood purification therapy, heme adsorption, etc. But the questions remain as to which patients would benefit, how early to start, what should be the Apache score at which you initiate, and so on. So it was really a very eye-opener in terms of the initial approach to the cytokine therapy. Now, I think the questions would be there on the chat. Right. So did the machine differentiate between harmful and harmless cytokines? What about extracorporeal modalities? I think there will be a lot of questions on the extracorporeal modalities. Would you like to answer a couple of them? Like which patients? Yeah? Yeah. So Dr. Molnar, which patients would you feel benefit the maximum from cytokine removal or cytosol therapy?
Well, there are several indications. Basically, I think intensive care has come a long way, and we are extremely well developed now. We have very detailed monitoring of the homeostasis, hemodynamics, respiration, whatever. And we have several very, very nice tools to improve the condition of the patients very fast, very quickly. And so we will save most patients within a few hours. And we will see patients who will just go dire straits and we were not able to help. So we need good, well-trained, devoted physicians to take a look at these patients and to select those who don't want to die, but don't want to improve either, to select this gray zone and define these patients. Now, this is very difficult. When I have been head of the ICU for 20 years now, and for me, I've been using Cytosorb for 6 years, and other adjuvant therapies as well. So for me, it was more or less a very straightforward process. The patient came in, we did our basic resuscitation, fluid, intubation, ventilation, vasopressors, and several patients improved. There were patients who developed increased lactate, metabolic acidosis, then we gave more fluid, we put an invasive hemodynamic monitoring in, there was still no improvement. And then we had to make a decision whether to let this patient go or do something else or just wait. And in those patients in whom we suspected that everything is, the source is controlled, there is no underlying pathology, the patient is just needs some extra help. The patient is going towards the right direction, but not at the speed we want. Patient is on high vasopressors, on mechanical ventilation. We put invasive hemodynamic monitoring, so other causes like hypovolemia, myocardial dysfunction is excluded. So all we have is hyperinflammation and vasoplagia. And this is the time when usually I decided to start blood purification.
I can see my co-chairman, Dr. Gopal Krishnan,
yes,
actually. Yeah, Gopal Krishnan, kindly
Gopal
take over.
Krishnan,
Yes,
please join.
Yeah, please take over.
Very good evening. That was a wonderful lecture. I was delighted to listen to the quote from Bhagavad Gita. First of all. Quite true. Yeah, that's right. I mean, it's $1 million question as to who is the candidate to really get benefit out of this extracorporeal therapy. That is $1 million question. And we would love to hear more from Dr. Molnar. Right now, we are in the midst of COVID crisis. We have been contemplating to go ahead with this kind of extracorporeal therapies, at least in situations where all other measures have been tried, but still patients continue to be sick. Thing is that with the limited availability of the panel of biomarkers, it's rather difficult to select the right kind of a candidate who will benefit. For instance, a patient with already renal failure and COVID crisis, the reliability of markers like ferritin and IL-6 is not that great, because a patient with CKD, already IL-6 and ferritin will be high, and what is the cutoff beyond which such patients help? All these confusing scenarios we are going through.
An excellent question. Thank you very much, Dr. Gopala Krishnan, because I've done several road shows in India on procalcitonin as well, which was one of my, which is one of my main research interests as well. And what I learned from those 25 years of studying biomarkers in the critically ill, that this is a very dodgy area. And initially, my team decided to start, for example, blood purification therapy in these patients based on high procalcitonin levels. But then it turned out that this is very unreliable. Procalcitonin is an excellent biomarker, but it shows a huge, as you said, a huge variation between patient to patient. You cannot really interpret one single measurement precisely, and you cannot really make any conclusion. So our philosophy, what we have developed over the years, was to watch the kinetics. So at the beginning, I would rely mainly on the patient's clinical course and clinical condition, and I would ignore the cytokines. That is true for IL-6 or whatever, because we just analyzed a huge database of cytosol registry, almost 1,000 patients, and very little to gain from cytokines because of the nature of cytokines, which reflects an individual response to an insight. It's not like blood sugar, sodium, potassium, or creatinine. It's very, very difficult to interpret. So I would go very, very cautious by using cytokines as an indication, and I would go and follow the patient's clinical course. And it is vasoplagic shock. This is the key issue. Vasoplagia is caused by cytokines, and if we cannot control this via conventional measures, vasopressors, second vasopressor, fluid therapy, so then it's time to intervene. The other issue is lung injury, ARDS, which is a top which is a top issue in COVID-19. If I had a patient after COVID-19 infection who develops ARDS, which requires ECMO therapy, this would be the time for me to start. However, there are some studies and some hints that we may be able to interfere with the cytokine release syndrome before actually we get to the dire straits with the patient. So whether preemptive use and defining those patients who will benefit from such an invasive and expensive therapy like extracorporeal blood purification before they develop actually ARDS, well, this is a very complicated issue, but maybe very, very relevant. But I can see that Professor Ronco has just written that many of these questions will be answered by him. So I don't want to take away the credit of Professor Ronco, who I really adore for decades now. So
I think,
Dr. Khanna, I think.
yeah, I think our time is up.
Yeah.
So they just would want to thank Professor Molnar for a great talk. Thank you so much for giving us an
Can we
opportunity.
invite Professor Ranko for his final comment on this, sir?
I think we are going to have his lecture, and Dr. Gopal Kishan, we can have it later. And he is also writing that many of the questions being asked at this time will be answered by him.
Okay.
So I think I thank both the chairpersons for a very, very nice discussion, and thank you so much, Professor Molnar, for a wonderful lecture. And Seema to introduce the chairpersons for the next talk. Thank you, Dr. Umesh Khanna and Dr. Gopal.
So moving ahead with, thank you. Moving ahead now with our next talk, which is on extracorporeal blood purification and organ support in the critically ill patient during COVID-19 pandemic, expert review and recommendation. And for the same, it's a pleasure to invite Dr. Vinay Sakuja, sir, who is Director Nephrology and Transplant Medicine at Max Super Speciality Hospital, Mohali and Bhatinda, Punjab, and Dr. H.S. Kohli, sir, HOD Department of Nephrology at Postgraduate Institute of Medical Sciences, Chandigarh. And I request Dr. Vinay Sakuja, sir, to kindly introduce the speaker for this session.
Good evening. Am I audible to all of you?
Yes, sir. Yes.
Yes. Thank you. So it's a pleasure to be here this evening, and I'm most grateful to the organizing team of Avatar 2020 for this very kind invitation. I also welcome my co-chairman, Professor Harbir Kohli from the PGI Chandigarh. So the next session, the speaker is somebody who's very well known the world over, Professor Claudio Ronco, who is the director of the Department of Nephrology at the International Renal Research Institute at Vicenza in Italy, the San Bartolo Hospital. And it's a pleasure to request him to deliver his talk on extracorporeal blood purification and organ support in the critically ill during the COVID-19 pandemic. Professor Ronco, please.
Well, thank you very much for this kind invitation. Good evening to everyone. And I'm very glad to give this talk just after Professor Molnar presented this talk, because I think there is a perfect sequence in the presentations. Before everything, I would like to bring the salute of our university, which next year is getting 800 years of history. And I hope that you will have the time to visit in person this university, maybe in the next years. Now, when we started dealing with the, when we started to deal with the the pandemic. We thought originally it was just a Chinese problem, then subsequently a European problem, and then finally we discovered that this was a problem from all over the world. We were not actually new to jump of viruses through species with the influenza H1N1 and H5N1. And we have been following the coronavirus evolution with the SARS that disappeared from 2004, while MERS was identified in 2012, and then it was finally identified to be transmitted with droplets, and still it is around somewhere. This virus jumped through species through a small mammalian, the pangolin, to the human being, and it was first reported in China in December 2019, and the virus was identified in early January with the subsequent somehow universal alarm through different countries. I must say that already on February 6, as you can see here from this paper we published in Lancet, we said we should prepare for extracorporeal organ support in intensive care, recognizing that this was probably a disease that would have affected many organs and would have required the support of extracorporeal systems. And in fact, a tsunami came into the ICUs, and we learned quite quickly to identify patients, although we recognize that we have asymptomatic patients, we have patients with moderate symptoms, and finally, we have patients with severe symptoms that actually affect part of the population and may end up in intensive care with specific radiological findings that sometimes are non-severe, but sometimes are really severe and may affect large part of the lung parenchyma. Now, very soon, we tried to somehow point out what was the involvement of the kidney in SARS-CoV-2 infected patients, and we wrote that this is frequently observed in patients that are affected by several different comorbidities, and especially in those patients who have already some levels of chronic decline of kidney function. This was often a disease determined by the immunoreaction and the dysregulated inflammatory response of the body rather than the invasion of the virus itself. And the use of extracorporeal blood purification techniques together with antiviral therapies could be theoretically more effective than antiviral therapies alone. Quite soon, presence of virus in the human kidney was identified by the group of Bergamo, Peremuzzi, and we published in Lancet Respiratory Medicine this cartoon in which we specifically identified several pathways through which AKI may occur. In patients with symptoms and severe involvement, there may be a direct damage to the kidney tissue with endothelial damage, podocyte localization, proximal tubular localization, mitochondrial dysfunction, and acute tubular necrosis. There might also be a damage induced by hypovolemia because many of these patients present with gastrointestinal symptoms. And finally, there are three pathways that go through. First, pneumonia, which can be further aggravated by ARDS and the presence of ECMO or mechanical ventilation, the presence of dysregulated release of cytokines with consequent endothelial dysfunction, and an hypercoagulable state that may also damage myocardial function or generate microthrombi into the kidney circulation. Through arterial underfilling, reducing cardiac output, and venous congestion, there might be another mechanism for AKI. So the problems was that we've very soon identified the fact that SARS-CoV-2 is a virus that actually infects the host and may cause a dysregulated response, but also may cause involvement of different organs, including the gastrointestinal system and the cardiovascular system. And in fact, specifically to the gastrointestinal system, we must say that many patients present at admission with gastrointestinal symptoms, or some may develop during the ICU stay. In any case, there is a high chance of bacterial translocation from the lumen of the intestine into the circulation, leading to a superimposed gram-negative bacterial sepsis. So the theorema of organ crosstalk in this situation with cardiorenal syndrome, hepatorenal syndromes, gut-kidney interaction, lung-kidney interaction was absolutely respected. And in order to respond to this organ crosstalk, we have proposed in the past that the blood is the common denominator of all these alterations that can be somehow modified or can be mitigated in its damage by using modified extracorporeal circuit, helping the heart with ultrafiltration, the kidney with dialysis, other situations with plasma exchange, or hemoperfusion for removal of cytokines, and finally veno-venous or veno-arterial ECMO, recognizing that we also may have extracorporeal CO2 removal for less severe situations. One of the issues that has been clarified was the severity of the disease may depend from the interaction between the virus and the immune system of the host. And there is an early lung involvement with cough, fever, high ferritin, high pro-inflammatory mediators, including cytokines, that are indication of an impending cytokine storm. High level of interleukin 6 have been identified. So early treatment of with pharmacological approaches have been proposed. But as Professor Molnar has recently said, there might be actually a situation in which trying with a magic bullet, it doesn't make sense because many other molecules are actually involved. So what other options do we have? Well, I would like to go back to the slide that Professor Molnar has recently presented, showing that after the insult, there might be a dysregulated response by the innate immunity, but also an anti-inflammatory response by the adaptive immunity. And patients may sometimes die hyperinflamed or immunodepressed. At this point, we don't know, because we don't have a biomonitoring system, when and how much pro-inflammatory mediators exceed the let's say, toxic threshold, and how much and when anti-inflammatory mediators do exactly the same thing. For this reason, we always proposed, but this was proposed also for sepsis, the possibility to have a magic shield, not a magic bullet. And this led us to propose the rationale for kidney replacement and support using extracorporeal therapies. First of all, there are patients with cytokine release syndrome, increased cytokine generation, and hemophagocytic syndrome, in which cytokine removal may actually be of interest. And this can be done by renal replacement therapy, by more permeable membranes, and also by adsorption. There may be organ crosstalk with involvement of different organs, including cardiorenal, hepatorenal, and other syndromes that may actually require extracorporeal organ support at the pulmonary level, but also eliminating the so-called dumps and pumps that are released. And finally, systemic effect can be balanced, removing not only endotoxin, but also cytokines and also uremia retention products in case of renal insufficiency. Of course, this led us to proposed the same concept that we proposed for sepsis, which is based on the cascade that moves from infection to the immune response that is dysregulated and to the organ damage, with the possibility of blocking or mitigating the effect of chemokines. So when the viral infection occurs and pneumonia occurs, this can be aggravated by ECMO, mechanical ventilation, and there may be a systemic cytokine release with dysregulated response in the pro-inflammatory and anti-inflammatory compartment, leading to endothelial dysfunction, shock, and organ failure. Well, if you use the peak concentration hypothesis, which was also illustrated by Professor Molnar, showing that it makes sense to actually have an unspecific removal, because we will be removing the peaks of the substances that in that moment will be at a higher concentration, either by using CRRT with special membranes or by using hemoperfusion. This will lead to endothelial protection and possibly organ support. Doesn't make little sense to measure cytokine because of the very short half-life, because of the unknown equilibrium between the tissues and the intravascular space. So the cytokinetic model is inducing us to look more at the clinical effects rather than to the biological measurement of cytokines. All these concepts led us to propose some recommendation in this paper from Lancet Respiratory Medicine that provides indications when there is oliguria, when there is hyperkalemia, azotemia, and so on, and how to prepare with different devices. Then preparing for potential extracorporeal therapies in different condition and situation, prescribing the therapy, and here in particular, we need to consider the prescription of the anticoagulation regime. Many of these patients are already anticoagulated, and therefore we need to adjust our anticoagulation. Finally, ensuring delivery, especially looking at the catheter, because these patients frequently require pronation, and therefore the problem may be that dysfunction of the catheter may occur. And finally, monitoring the effective delivery of the dose and the ultrafiltration in the patient. As I mentioned before, inflammation is a necessary evil, but however, the life and the response depends on the balance between inflammation and anti-inflammation. And the idea, both in a sequential way or in a parallel way, to remove the peak of the concentration of these molecules may actually help mitigating the response. But there is another issue, and the issue is that everything can also be aggravated by the presence of endotoxin in case of superimposed sepsis. And we have seen many patients with superimposed sepsis. And in this case, removal of endotoxin may become extremely interesting. So when you have infection with the virus, you take care of the possibly removal of virus, but viremia in this case is not very high, so this is not an effective therapy. Cytokine mediator removal, this is very, very effective, and then organ failure can be replaced by organ support. In case you have a superimposed sepsis, makes sense in this phase to, of course, recognize the source of infection, but also to remove endotoxin, and then proceeding with the removal of cytokine and then supporting organ. This is what we have been calling sequential extracorporeal therapy. Again, removal of virus or removal of endotoxin can be the first part leading to a less important activation of the monocytic response and production of cytokines. Then subsequently, removal of cytokines and other inflammatory substances, DAMPs and pumps substantially, have to recognize that they are located in a range of molecular weight that normally is not cleared by standard membranes. So membranes, which are characterized by pore density and pore size distribution, have in pore density the effectiveness to remove small molecules and to produce ultrafiltration. But what creates a removal of larger molecules is the profile of the membrane sieving curve. And as you can see here, high flux membranes have a very different sieving curve compared to molecules with we call medium cutoff or high cutoff that approach the permeability of the human glomerulus. New MCO, medium cutoff membranes, also defined as high retention onset molecules, have shrinked the distribution of the pores, and they've moved the median of the size of the pore to the right, getting close with the cutoff to the molecular weight of albumin. The important thing has been the change of this shape that has moved the point in which the sieving coefficients start to be 0.9 from an ideal molecular weight of 2,000 to a molecular weight of 10,000, which describe a capability to remove significantly the so-called middle or large middle molecules in the body. Here is again this typical effect. Now, these membranes have an important characteristic that the cutoff membrane is close to the one of high flux membrane. So they are different from high cutoff membrane because high cutoff membrane can only be used for a few sessions because of leakage of albumin. Another possibility is to use membranes that are specifically characterized with absorption capacity. And this is the case of polymethyl methacrylate or AN69ST membrane called Osiris, for example. In this case, this membrane is binding polyethylenimine and possibly heparin with the capability to remove endotoxin and being bioactive in removing cytokines. In fact, cytokine clearance from TNF-alpha to HMGB1 are significantly higher than any other type of membrane. Another option is to apply directly a sorbent to the circuit, and this has been done with Cytosorb, which is a specific resin which has been made biocompatible with the capability of removal specifically of pro-inflammatory cytokines and other different substances, including drugs, and this has been needs to be considered when you treat the patient. Other special neutral macroporous resins have been developed over the years. This is the case of a device that is called HA380 from Jafron, China. And this has been significantly applied during the COVID-19, also in our own center. This can be placed before the filter or after the filter, or it can be placed isolated in a simple hemoperfusion circuit. This is the case of a COVID-19 patient with cytokine release syndrome. He was admitted to the hospital and ICU with fever, hypotension, respiratory failure, placed on mechanical ventilation. He displayed hemodynamic instability, high cytokine levels, high ferritin, CRP, hypercoagulable state. He was placed on hemoperfusion for 3 days. And on day 8, we saw hemodynamic stabilization, normalization of cytokine levels, decrease of inflammatory parameters, and improved pulmonary exchanges until extubation. One of the interesting findings is our standard biomonitoring, let's say, of our therapy, which was clinically relevant, stability of mean arterial pressure, decrease of norepinephrine administered to the patient, decrease of interleukin-6, and somehow a restoration of the monocyte response to TNF and to capacity of do perform phagocytic function. Finally, there was a restoration of the HLA-DR expression, which is the capacity of the monocyte to express the antigen. And this 48 hours later displayed a significant improvement showing that there is a kind of modulation of the immune system. This hemoperfusion system can also be applied in conjunction with the ECMO circuit, and by doing this, you can remove the extra production of cytokines that can be produced during ECMO. Because of the search for evidence, we recognized in our paper in Lancet that there are research priorities. Well, I'm not sure that we will ever be able to have randomized trials getting the level of evidence that some people seek. On the other hand, many of the action in the ICU are not done based on randomized trials or high level of evidence. Nevertheless, I think we need to explore, for example, the use of tubular damage biomarkers to predict and manage AKI and to define which patient may benefit from the application of extracorporeal therapy. Studies should try to identify how early we should initiate. Our experience and recommendation that we made with the ADKI group that very soon will publish a paper on this is to start quite early before any type of organ damage develops. Of course, the role of hemoadsorption on cytokine removal should be studied in depth, and also we should consider the importance of low flow extracorporeal CO2 removal. Finally, there are patients with superimposed sepsis, and this should be studied especially to try to apply the so-called sequential extracorporeal therapy, endotoxin removal, cytokine removal, immunomodulation, and finally extracorporeal organ support. With the virus, we have been challenged, and I must say that in the very critically ill patient, extracorporeal therapies have helped us in many ways, with the possibility to support organs with ECMO, the possibility to remove cytokines with hemoperfusion or special membrane, the possibility to cut the peaks of cytokines according to the peak concentration hypothesis, to the possibility to manage organ failure, especially with the use of medium cutoff membrane in the recovery phase and in those patients who are still on acute kidney disease and did not recover fully renal function. And finally, to manage fluid balance in this patient. Please follow my YouTube channel, Cappuccino with Claudio Ronco. I have presented many of these cases in the Cappuccino series, and you're all invited to join the Vicenza course this year, completely virtual, in the www.irib.com. The registrations are open, and we hope to have a large number of friends from India and all over the world to register and participate. And with this, thank you very much for your attention.
Thank you very much indeed, Professor Ronco, for that very stimulating presentation. I'll now request Professor Kohli to guide the discussion from this point onwards. Professor Kohli, please.
Thank you, Professor Sapuja. And Professor Ronco, anything which is said in critical care nephrology always has your stamp, be it CRRT, be it equipment. Either it has been designed by your group or it has been tested by your group. So naturally, one tends to get swayed whenever we listen to you. Now, here, since we are talking of a particular infection, that is COVID here, organ support, there is no confusion. Everybody agrees that you need extracorporeal therapy for organ support, managing a fluid balance, everything. If we look back at the literature, not by the randomized trials, only for sepsis alone in the intensive care unit, again, it depends upon whether to use such cytokine removal systems, different systems, sorbent-based or otherwise. But here, what you described is cytokine peak, which is unique to COVID, that you have to tide over somehow that crisis, that peak. If you start early therapy, maybe with the drugs, you won't let those cytokines to be there. But if at all cytokines are there, you get it removed with some form of a therapy, and maybe it will enhance the recovery. And once the organ failures has occurred, then possibly then it's just a supportive therapy. Now, when to know that that cytokine peak is there? I mean, conventional parameters, do we have some guidelines or something based on your experience? Okay, cutoff of this IL-1, IL-6, this much, 7, this much, or ferritin this much, etc., etc. Now we are heading towards the peak. It's better. Or all the patients then should be on this form of therapy. Professor Ronco, please.
I would like to reinforce and second what Professor Molnar has presented before. The situation of sepsis and the situation of severe COVID infection are somehow depending on the dysregulated immune response. And clinically, this is evidently present because of vasoparalysis, hemodynamic instability, high level of inflammatory markers. Now, I cannot measure every 20 minutes cytokines. I can measure sometimes cytokines to for a confirmative, let's say, suspect. But in general, my suspect is clinical. And because we don't have a continuous monitoring of the peaks and valleys of pro and anti-inflammatory mediators, it makes sense, according to the peak concentration hypothesis that I remind you, we put forward in 1995, that a specific removal of cytokines will be probably leading to more removal of those cytokines that are at the highest level. By doing this, we try to achieve what we call immunohomeostasis. Using the comparison that Professor Molnar presented before, we are not teaching, we are not substituting our system to the immune system. We are trying to teach the immune system to operate in the right way. So basically, we are partially reconditioning the system, avoiding the so-called endocrine effect of cytokines that are completely disrupting the immune response. So one of the experience that we have had with the COVID-19 is that we need to start early, because if we decide to start when the damage to the endothelium and the organ has already been done, then in this case, often is too late.
Thank you. Thank you very much, Professor Ronco. Now we can have questions. I mean, at the moment, okay, Dr. Arvind Kumar says, can plasmapheresis be used for cytokine removal in resource-limited setting?
Can you repeat, please?
Can plasmapheresis be used instead of the filters HA380 or CytoSorb, etc., and has the desired outcome?
Oh, okay. You mean plasmapheresis?
Yes.
Yes.
Yeah. Theoretically, yes. But the problem is that the production of cytokines can be so overwhelming that the rate of exchange of plasma normally used in plasmapheresis can be too slow. So it is much more efficient to use hemoperfusion techniques that selectively remove these substances directly from the blood.
Okay. Thank you, Dr. Arvind. You got your answer for that. In the last talk, we were Okay, Dr. Anuradha asked, can plasma therapy be given? If yes, when?
For plasma therapy, I suppose they intend, the question intends the plasma from subjects that were healed from the COVID-19 infection, so they are rich of antibodies. And this is still under evaluation, I think. So it seems to be a positive approach. But there is an experiment done by the group in Bergamo that used cascade filtration, trying to concentrate IgG and IgM from the healed patient and infuse them in the patient. Otherwise, you may be forced to infuse large volumes that sometimes are problematic in the critically ill patient.
Okay, Dr. Ronco, we have now a series of questions. Some of them are interrelated to your comment that we need to start it early. Now, early, obviously the question is early means what? And you answered that you go by the clinical condition rather than by the markers. And so Dr. Shankar Prasad asks, is IL-16 level, are you considering IL-6 level you are considering? While Dr. Soundarajan is saying that early initiation will invite immune paralysis, leading to added sepsis. So no, these are the two linked questions. So what's your opinion about that?
So the problem is when we don't have stringent evidence, we should go for a rational application. So the rational application also goes in conjunction with the small but continuous experience that we mature during the treatment. And our experience was that in those patients in which we applied the extracorporeal treatment for cytokine removal in an early phase, before, for example, AKI developed, they never developed AKI and they never developed myocardial dysfunction, while patients that had this situation and were not treated with extracorporeal therapies, some of these patients developed AKI subsequently and developed multiple organ dysfunction. The other thing is the number of patients that incredibly develop a superimposed gram-negative bacterial sepsis. And these are patients in which you need to start the approach that we normally use for sepsis, which is the use of endotoxin activity assay measurement. And if this exceeds 0.6, we then start with polymyxin B hemoperfusion for removal of endotoxin. And subsequently, we use either cytosorb or Jafron HA380 for removal of cytokines.
And I think, again, the question by Dr. Raghuvinder Singh is that how many sittings will be required? How will you be guided? Is it clinical parameters or again the lab parameters? I think you answered in that way that it is mainly the clinical and then the possibility, or you want to dwell anything on that?
Yeah, of course, lab investigation is important. For example, LDH, CRP, other measurements like albumin, all represent important information in terms of high level of inflammation. But what I'm saying is that these are confirmatory tests that we do once we suspect a high level of inflammation and hemodynamic instability starts to become evident.
I think we don't have any more questions. In the last talk, you were jotting down some questions which were being asked that maybe for Dr. that you will be answering. You have anything for the last minute, Professor Ronco? Any last minute comment?
Well, I think that I was very happy that Professor Molnar gave the talk before mine, because I think the two talks are really integrated and they are perfectly useful to follow the sequence of the problem. Still, I think until we don't have a biomonitoring technique that tell us which situation is the patient in a specific time frame, which could lead us to use, for example, steroids or other different specific drugs. Until that point, removal with extracorporeal therapies is probably a specific but helpful, because as Professor Molnar has said, we are putting the net and try to fish somehow one-to-one. But if there are more sardines than other fishes, we will capture more sardines. So if we will have too many anti-inflammatory mediators, we will capture more of them compared to the other situation. And we will try to restore the immune response.
Thank you, Professor Alko. I think that answers Dilip Jadav's question, pro-inflammatory versus anti-inflammatory cytokines, the balance. And of course, Professor Molnar conveys his thanks to you, and he agrees with your viewpoint. I think it has been a wonderful lecture and a lot of thought process, a lot of the things to do. Let's see how the COVID goes on, because at the moment in India, it is almost going towards its peak, I hope, and with the multi-organ failure patients coming in more and more. With that, Professor Sakhuja, you want to say anything, or should we find out, sir?
No, that's fine. Thank you very much indeed. I enjoyed that presentation and the discussion that followed. But my conclusion at the end of all this is that there still is a lot of uncertainty about how to decide the precise timing of the extracorporeal blood purification systems that one needs to apply to the patients that we are encountering with COVID-19. That's all I'd like to say. Thank you very much indeed.
That's true. However, I would strongly recommend that uncertainty should not guide nihilism, because otherwise we will end up doing nothing and waiting. And until we wait for more evidence, patient may die. At least, as Professor Molnar has said, we're not sure if we do the right thing, but we do everything to try to do the right thing.
Yes,
certainly. I would fully agree with that. I would keep an open mind on that issue, certainly.
So, thank you, Professor Sakhuja, Professor Kohli. And it has been a pleasure to hear your talk, Professor Ronco, as always, and it has been very illuminating. Only thing is $1,000,000 question, when to start or what is the right time. I think with this, we close this session. Thank you, Professor Sakhuja and Professor Kohli. And over to Seema for introduction of speakers for the next talk.
Thank you, respected faculty members. So with this, we move ahead to our third session, which basically has two talks. So I invite our respected chairpersons, Dr. Manisha Sahay ma'am, who is Professor and Head, Department of Nephrology at Osmania Hospital, Hyderabad, India, and Dr. Prachi Sathe, Director, Intensive Care Unit, Ruby Hall Clinic, Pune, India. And I request Dr. Manisha ma'am to kindly introduce the first speaker, who would be talking on extracorporeal strategies to handle cytokines in sepsis and cardiac surgery.
Good evening, everyone. At the outset, I would like to congratulate Avtar and thank Avtar for inviting us here to chair this session. Dr. Yatin Mehta is a very erudite speaker. I've heard him before this as well. He is the chairman, Institute of Critical Care and Anesthesiology at Medanta, the Medicity Gurugram. And I'm looking forward to this talk. Over to you, Dr. Yatin.
Thank you, Dr. Sahai, for the kind introduction. I want to share screen.
Someone is stop you from sharing screen. Yes, yes. Which one?
So he's going to talk about the cytokine removal in sepsis and cardiac surgery. Yeah, Dr. Mehta, you'll be talking about the sepsis aspect.
Okay, thank you, Dr. Sahai. Thank you, the organizers of Avatar, for inviting me. Indeed, a pleasure. I've become a regular speaker with my dear nephrologists. So I'm going to talk about the role of cytosol in sepsis first, and then in cardiac surgery. I bring you greetings from Medanta, the Medicity, outskirts of Gurgaon. And we have had some very good talks from Professor Molnar and Professor Ronco. It's a very difficult act to follow. And they have talked about cytosorb. Basically, it's an adsorber. It's not a filter. It's got a huge surface area. And it absorbs, according to the concentration of the substances, certain molecular weights. And the surface area is like 4 full-size football fields. And as I said, the removal of the substances or absorption of the substances depends on the concentration of the substances. So if the concentration is high, there's a large removal. When the concentration gradient reduces, the removal also reduces. Nihar? Nihar? Okay.
Yes.
Now there is some technical issue. Okay, yeah. So these are it removes the inflammatory mediators, anti-inflammatory as well as pro-inflammatory mediators. It removes certain endotoxins, and it removes certain metabolites. Myoglobin, you're worried about nephrologists for the rhabdomyolysis. Bilirubin, hyperbilirubinemia itself can damage. It absorbs free bile, bile acids, ammonia, and free hemoglobin. And certain chemicals are removed, which I think Dr. Ronco had shown, particularly the newer oral anticoagulation. And as it is a balance between PAMP and DAMP, balance between the cytokine storm, which decides which way the patient is going to head. Ultimately, if the pro-inflammatory cytokines are excessive, vasoplegic shock, multi-organ dysfunction syndrome, and ultimately death can happen. So this we see every time when we see, even now with you had a lot of discussion on COVID-19, and this is a common phenomena, the cytokine storm in the second week of COVID. So you have a cytokine storm, you get vasoplegic shock, you get organ perfusion, malperfusion, you have capillary leaks, interstitial fluid is increased, the fluid in the lungs increases, extravascular lung water, cardiac function deteriorates, and ultimately the patient will die. And how do you attenuate? So at that spot of time, if you use this adsorber, you can attenuate and maintain the capillary integrity and attenuate the worsening of the endothelial leak and damage. And cardiac function can improve, microcirculation improves, and significantly all the studies have shown reduction in vasopressor requirement. So invariably, most of the studies have shown hemodynamic stabilization and reversal of shock with significant reduction in interleukin levels. So as now definition of SIRS in the new sepsis definition has changed. It's no more SIRS now. But anyway, initial definition of SIRS and sepsis and septic shock as it progresses, initially you do not forget the standard of care, which is volume replenishment, vasopressor support, maintaining perfusions, antibiotics, source control. So all these things have to be done before you look at adjunctive therapies. And so when to apply them? Well, earlier you apply, the better it is for the patient. So what happens when the patient initially may be stable, mean arterial pressure is maintained, your kidneys are perfusing well. If the mean arterial pressure is less than 65 over a period of time, vasopressors, you bigger the vasopressors, the dose of vasopressors is going up, your lactate getting higher and higher, the organ failure starts coming in. So that is the time when you should use these filters. And by and large, most of the German studies have shown the interleukin levels to be more than 500 and procalcitonin to be more than 3 when they start. Also, when adjunctive therapy is already begun, like say CRRT or ECMO or hemoperfusion, then that time it's easy to put it. And here you can see that it can be put in various circuits. I mean, hemoperfusion circuit can be, instead of the hemofilter, you put a adsorber. In cardiopulmonary bypass, in heart surgery, we can use it after the pump head, and it pumps through the thing and goes back to the venous reservoir. In CRRT circuit, you can put it in pre-filter or post-filter, it doesn't really matter. And in ECMO circuit also, you take it after the pump, you take a diversion from there, and then it goes to the filter. So as it is compatible with every dialysis machine, hemodialysis, lead, CRRT, so all modalities are compatible, and also it can be used in any ECMO circuit. It's very easy to attach the ECMO circuit. And as you can see here, this is the first is the post-oxygenator site in ECMO. In this ECMO circuit, the CRRT outflow is connected with the centrifugal pump, and CRRT third on the right side, the image is CRRT combined with ECMO. And here is the cardiopulmonary bypass circuit where it can be used after the pump head as a filter. So as I said, how long do you continue to give it? Well, if the patient after the first device has improved significantly and inotropes are almost down to 10% of the original dose, you can stop the cytopop. You need not use the second device. If the stabilization has happened, the device you stop using, and the patient starts getting worse, that's the time to use the second device. And the hemodynamic stabilization does not happen, and if the patient continues to deteriorate, then maybe there is no point. It may be too late to use the device. So potential indications for this device is refractory septic shock, vasoplegia secondary to even any therapy or ECMO therapy, toxic shock syndrome, it removes the endotoxins, meningococcal sepsis, HLH, which is a phenomena in COVID-19 also, pancreatitis, burns, trauma, liver failure, rhabdomyolysis, and certain overdose of drugs, including, I think, snake bite also it has been used. There are multiple papers which have been published, overall 111 RCTs till now, and all the papers, as I said earlier, hemodynamic stabilization, reduction of vasopressor requirement, and improvement in organ function. And some studies have shown mortality benefit. So this was a earlier paper where noradrenaline level was significantly reduced, lactate clearance was significantly improved. Another paper where mortality was significantly reduced from the expected mortality. And this was a simulated studies where the number of patients required to save one life was 4. If you remember earlier days of Zygris therapy, it was 16 patients if you had to use it to save one life. So it's a pretty good number to use that. And this was a use with liver failure and rhabdomyolysis. This is a case study. Again, significant reduction in myoglobin levels, CPK levels, and improvement in renal function. Cardiac surgery, it has been used quite extensively, particularly for complex cardiac surgery, where the pump time is long, where the damage to the blood cells is much higher, coagulopathy is more, organ dysfunction is more. So, and it invariably, because of the foreign surface, it invariably inflammatory markers are raised in this, and sometimes vasoplesic shock also happens. And obviously, many times you find kidney and liver dysfunction after complex cardiac surgery. So how does one take care of that? So again, we had these 3 publications. One is on sepsis and 2 are in cardiac surgery. So I'll just run through them quickly before Dr. Molnar takes over. So this was a paper by us published in for 100 consecutive patients of severe sepsis in a single center, that was Medanta, and after the EC approval. Baseline characteristics were recorded in all patients. And you can see we divided the patient groups into survivors and non-survivors. So, and demographically, they were all almost comparable in the beginning. There were 40 survivors and 60 non-survivors. And as you can see, now this was survivors, all the vasopressor requirements significantly went down, and mean arterial pressure significantly improved after the device was used. While in non-survivors, there was no benefit of using the device. The vasopressor requirement went up and mean arterial pressure went down. That's why the patients ultimately died. Again, if you sepsis score in the survivors, there was a significant reduction in severity of sepsis scores, and non-survivors, the score did not change. So they remain sick. Again, if you look at it, significant improvement in post-cytosol values in serum lactate levels. Non-survivors, in fact, lactate levels increased significantly. Coming to the interleukins levels, significant fall in the survivors in the all inflammatory, pro and anti-inflammatory cytokines significantly reduced in the survivors. How did it differentiate? Well, if it was used within 48 hours, the mortality survival was 70%. But if it was used after 48 hours of the patients getting admitted with severe sepsis, the mortality was, the survival is 30%. Significant difference. So earlier you start, the better it is. So what did we conclude from this particular study in the sepsis? There was all patients in which we used reduction in vasopressor requirement in survivors, hemodynamic stabilization, improvement in the severity of sepsis scores, improvement in lab parameters. Earlier we used, the better the outcome. Coming to my experience in cardiac surgery. Now, as I said, major cardiac surgery associated with significant inflammatory reaction and end organ perfusion failure. So this was a small study. It was a pilot study, 8 patients in each group. And this was major aortic surgery. Not only the valve replacement, this was aortic arch and aortic ascending aorta replacement. So this was major aortic surgery with long pump time, and some of them with hypothermic circulatory arrest. And this was a retrospective pilot study. The control patients were no adsorber was used, and study patients adsorber was used. The time points of measurements was before cardiopulmonary bypass, 1 hour post cardiopulmonary bypass, day 1 of cardiopulmonary bypass, and day 3. And we measured interleukin 6 levels and other parameters at all these time points. What did we find? Significant difference in control and study group in interleukin 6 levels. As I said earlier, most of the studies have shown significant reduction in procalcitonin level at all time points. Significant improvement in mean arterial pressure in the study group. Significant reduction, not significant statistically, but otherwise good reduction, 2 days reduction in post-op ventilation, and reduction in ICU and hospital length of stay in the control, in the study group. So in patients undergoing major aortic surgery on cardiopulmonary bypass, we concluded the cytosol use leads to significant reduction in interleukin 6 and procalcitonin levels, higher mean arterial pressure with reduced vasopressor requirement, improvement in the PF ratios, and shorter duration of hospital and ICU length of stay and mechanical ventilation. And this was a case report which was published. As you can see on the left side, the filter cytosorb adsorber, before we put it in the circuit, in the middle one, it's while in the circuit, and the third one, how much of bilirubin it absorbs. So much of bilirubin is absorbed, so even the gloves of the nurses turn yellow. So this was a patient which we had within 3 hours, 8 hours after. This was a redo valve surgery. It was a foreign patient, a significant reduction in myoglobin levels, and it declined for the second after the second use. Also, you can see it in the graphs there. So in this patient's condition improved subsequently. Renal function completely recovered, not requiring RRT, and finally patient was transferred to the ward on day 22 of this major cardiac surgery. So it is easy to use the device. Anticoagulation is as usual with a bit of heparin. It can be used with any CRRT circuit. There are a large number of publications and large number of users. More than 1 lakh users have happened worldwide, and in even the COVID, more than 1,500 users happened. So summarizing, sepsis as well as major cardiac surgery elicit cytokine storm. Inflammatory cytokines can be detrimental to organ perfusion. Cytosorb absorbs inflammatory cytokines, myoglobin, bilirubin, bile acids, certain drugs. It may improve survival, reduce ICU and hospital length of stay by reducing cytokines, TCT, vasopressor requirement, and improving organ function. Thank you very much for your attention.
Thank you, Dr. Mehta. That was a very lucid presentation with well-documented studies you've done with your own experience. So I would like to ask you, doesn't it also remove the anti-inflammatory cytokines along with the pro-inflammatory cytokines? This is one thing. And how do you compare cytosorb with other modes of extracorporeal therapies available in the management of sepsis and cardiac surgery?
Very good question. Well, it does remove both anti-inflammatory and pro and anti-inflammatory cytokines, but it basically restores the balance. As I said, now it depends which is higher. If the pro-inflammatory cytokines are very high, it will remove that more. So the balance is restored. But both are removed, yes. And what about the use of others? When the use of other filters, hemofilter is used quite regularly in cardiac surgery. But that the removal of the cytokines is very little with that. And Oxyris filter or Torre filter have not really been used in cardiac surgery. There are no real published reports of it. But in this cytosorb, not filter, but cytosorb adsorber has been used quite extensively in cardiac surgery. There are large series, even in aortic surgery, major aortic surgery, there are more than 100 case series from Germany, which are published with very good results. It has been extensively used in organ transplantation, heart transplantation, lung transplantation, heart and lung transplantation, and also bacterial endocarditis. Because these patients are septic patients, they're quite sick patients when they undergo cardiac.
Good evening, Dr. Mehta. I'm Dr. Prachi here. Can I ask you one question?
Yes.
It is a very nice study which you have shown in extensive cardiac surgeries, but most of these patients was cytokine therapy decided, cytokine removal therapy decided preemptively or at the onset of some deteriorating signs.
Are you talking about the sepsis patients or the
cardiac patients?
Cardiac patients, it was decided beforehand, but for major cardiac surgery. There's no point of using it just for bypass or a valve replacement surgery. No.
Right. So it was unrelated to the measurement of any cytokine levels, right?
Correct.
Right. Okay. And then it was compared with the patients who were not given these therapies as well.
Correct.
Excellent. Any more questions from the audience?
There's a question from Dr. Sandarajan in the chat box. He wants to know, how do you compare high volume CRRT versus cytosorb? Both remove hydrophobic substances.
Well, this question should have been directed to Professor Ramko, but I will be able to answer to some degree. See, high volume CRRT also removes the cytokines, but the removal is not as good as cytosorb device. So it does remove, but at a much slower rate.
And non-selective, more non-selective, I suppose. Whereas cytosorb is more selective, as the kilodaltons were mentioned in Dr. Molnar's talk.
I can't see any other questions in the chat box. I think Dr. Yatin has cleared almost all the doubts, and he has presented convincing evidence about the role of cytosorb. So I know that the evidence as of now, I mean, controversies do exist, but these are exciting therapies and have been helping COVID and non-COVID patients as well. So I think with that, do you have any questions, Dr. Prachi?
No, I think we can move ahead. This was an excellent depiction.
So we have, I think exceeded the time also. So I would thank Dr. Yatin for a very crystal clear presentation. He has made his point, and we thank the organizers again for inviting us to chair this session. It has been an honor for us. Thank you. I hand it over to the organizers. Thanks a lot.
Now we'll request you to stay.
You have to conduct the second talk also.
Second session.
Yeah.
Okay.
So I'll request
Dr. Prachi.
Yeah. Thank you very much. It's a pleasure to be here with Avatar 2020, because the topic which has been chosen for today evening's session, which actually narrows down the boundaries between the nephrologists and the intensivists. So we all have to work together in certain scenarios. While sepsis has got defined as dysregulated immune response, the black box of immune reactions is still not fully unraveled its secrets. And COVID has probably added to that. It has made everyone aware of cytokine storms and IL-6. Even the non-medico patients are asking us about IL-6 levels when we are treating critically ill patients in the ICUs. But while IL-6 is the only one of pro-inflammatory molecules, there are so many PAMs and DAMs which are causing harm if the levels remain very high. But like antibiotics in sepsis, antivirals in COVID are not able to calm the cytokine storm and the organ damage. So we need obviously something beyond that. Tocilizumab tried as a magic bullet to block the IL-6 receptors. But as it was mentioned by Dr. Ronco in his talk, that we need to have a bigger umbrella or more non-specific cover rather than just one targeted molecule which is being prohibited. So basically, there is a very small window of opportunity while trying to treat the COVID-19 patients. And I would request Dr. Molnar to come again on this dais to present his talk about use of extracorporeal therapies for cytokine removal in COVID-19 and beyond. Dr. Molnar, please. May I hand it over to you? Yes, we can see the screen. Yes, Dr. Zold, you can go ahead. I think you are muted. You need to unmute yourself.
Okay.
Okay, welcome.
I'm sorry about this. I really wanted to be on time and then I just clicked on the wrong button. So thank you very much for having me again with this next talk on COVID-19 and beyond. And it is a great pleasure to talk after my good friend Yati Mehta. And I am really sorry that we cannot share these moments together after the session and have a lovely Indian food and a good glass of wine. But this is how it is. And it's all because of this little bug called COVID-19. Okay, so let's see how the concept of blood purification and cytokine removal fits in this picture. So let me take you back without really going back into all the details, but let me take you back to this, one of my favorite figures from Didier Payen and co-workers, in which you can see the innate and adaptive immune response, which we can call the pro and the anti-inflammatory forces, which activate themselves when there is an insult, there is an injury, there is an infection, regardless whether it is trauma, surgery, viral infection, bacteria, fungi, whatever. And if we are healthy, then after being very ill, you have high temperature, you feel awful, you have aches and pains, if you are healthy, your immune system will get the situation under control and you will recover. Well, if you are, if the injury finds you in the wrong phase of your life, then this goes out of control and the patient will enter into a condition that we call nowadays as dysregulated immune response. We call it hyperinflammation, we call it cytokine storm. And these patients are in really in a life-threatening situation. So attenuating this burden of hyperinflammation with hemoadsorption certainly has some physiological rationale. And the device that we use, and this is a slide, has already been shown by Professor Mehta, that this, with cartridges like this one, like the CytoSorb, which includes some kind of components which are biocompatible, they have high absorption area, which in the case of CytoSorb is equivalent to 4 soccer or football pitches, as we call them in Europe. and they absorb molecules regardless within a range of anything up to 60 kilodalton, which is exactly the range for cytokines and inflammatory mediators. So it may have a rationale. And the first data came from animal experiments from, again, John Kellum's group from Pittsburgh. And what they did, they developed an animal experiment of cecum ligation and puncture, the so-called CLP model. And after 20 hours of the CLP, the animals developed septic shock, peritonitis. And then they randomized the animals into two groups. One of them was treated with the cytosorb, and the other one was the control group. Now, dark columns represent the cytokine levels of the cytosorb treated animals with septic shock, and the white columns are the control group. And you can see that after a few hours, after 3 hours, there was a significant difference, regardless whether it was pro or anti-inflammatory cytokines. So this is the animal background and the experimental rationale of using hemoadsorption and cytokine adsorption in septic shock. And this is our study, which was unfortunately just a proof of concept controlled study, pilot study. But we randomized 20 patients into 24-hour cytosorb treatment versus 24-hour no cytosorb treatment. And these were patients who were really ill with a very high vasopressor demand and elevated PCT on mechanical ventilation, very high severity scores. And what we found, that just one single 24-hour treatment of these patients resulted in a 70% decrease in vasopressor need, while there was no significant change in the control group. And procalcitonin also reduced dramatically, especially during the first 24 hours of cytosorb therapy. So this was a preliminary data, and the strongest possibly evidence of the positive outcome we have so far is this retrospective propensity score match study from Rotterdam, from the Netherlands, in which they retrospectively evaluated the results of 100 or so patients treated with cytosorb compared to those who were only treated with CRRT but no cytosorb. So what they found was that the predicted mortality was higher in both groups. And in the cytosorb group, there was a more than 25% reduction in the actual mortality, in the observed mortality as compared to the predicted. And when they performed a thing called, it is a stabilized inverse proportion of treatment weight analysis. So they basically balanced out the groups. They created a dummy group from the control arm, which was as severely ill as the cytosorb arm, and then they evaluated the outcomes. Then it revealed an almost 20% reduction in the cytosorb treated patients as compared to controls. So what we have so far are positive signals of case series, case reports, retrospective data, and prospective small studies. And it may also improve survival in addition to reducing the circulating level of serum cytokines. Now, what about COVID-19 patients? Well, this is a figure I took from the company, which this is an old figure, but this is very nice because it depicts that cytokine removal is not within the domain of sepsis only. You can use it for burns, surgery, trauma, and of course you can use it for influenza and the most dreaded complication, ARDS in COVID-19. So this all falls within the possible indications of cytokine removal. And don't forget that removing of cytokines aims to regain control between the pro and the anti-inflammatory forces, to regain balance and to treat the imbalance between those two equally important forces. Now, what happens in COVID-19 is very nicely depicted in this paper by Tai and co-workers, published a couple of months ago. And it is a nice summary of the trinity of COVID-19. And it's all about immunity, inflammation, and intervention. This is the trinity. And what you can see here on the first figure is that our immune system can protect us via several measures from the virus. It can clear it from the lungs, no problems. If a cell becomes infected, there is cellular immunity. So in other words, about 80% of the population will sail through COVID-19 without any major symptoms. However, there is a minority of patients who get infected, and then they develop the dysregulated immune response. And due to this, the host immune response can overwhelm anti-inflammation, and then these patients can develop all the symptoms that are very similar to septic shock, including systemic cytokine storm, pulmonary edema due to increased capillary leakage in the lungs, and widespread inflammation and multiple system organ failure. And the same authors in the same article also depict several possible interventions via which we can potentially handle the injury and the insult. And one of them is mechanical removal of the circulating cytokines. And the authors go as far as they suggest that controlling inflammation may be as important as targeting the virus. A very new concept. I really like this concept. And this was also emphasized very early during the COVID-19 pandemic by Claudio Ronco, Jean-Louis Vincent, Paolo Navalesi in a point of view paper, in which they emphasize that new extracorporeal organ support therapies, including chemoadsorption and hemoperfusion, designed to remove cytokines and other circulatory mediators should be considered. So without any clear evidence, the pathophysiological rationale is there. And we have mounting data, at least, to support that some patients do benefit from these approaches. So possibly this is the reason why the FDA gave emergency use application in these patient group for hemoadsorption with cytosope, and also in India you have an approval to use extracorporeal blood purification. But it's not only the US and India. There is the World Health Organization, China, Colombia, Italy, Panama, Great Britain, Germany, Israel. It is a written concept recommendation that you can reach out for this technology and therapeutic modality in these patients. And physicians started to use it. And this is a case series, 3 cases from the United States. And I am not going to show you the video, but if you click on this link from my presentation, you can watch the full video that is presented by Dr. Lucian Durham. And he was interviewed on American television. And he treated patients with severe COVID-19 caused ARDS and ECMO. And these patients in southern Wisconsin were recovering after the treatment. They had very good experiences. So the therapy is gaining ground all over the world. And especially in the most severely ill patients with acute respiratory failure who require extracorporeal membrane oxygenation. It was shown in this very recent study when they compared 13 cytosope treated patients to 7 control patients. Again, retrospective study, case match. So it's not a prospective randomized study, but you can see a very nice pattern of decreasing PCT levels and decreasing norepinephrine requirement, whilst it wasn't as dramatic or non-significant at all in the control group. And they concluded that cytosope in combination with the ECMO is an effective alternative therapy. Then this is some preliminary data from Germany, from Alexander Supadi's group, which was just recently published in Critical Care. And they are planning large studies, but this is a preliminary study indicating that those patients admitted to the ICU with COVID-19 requiring ECMO and were treated with cytokine adsorption, they had a dramatical decrease in IL-6 levels as compared to those patients who were not treated with cytokine adsorption. So based on these observations, there are several studies now published on criticaltrials.gov. This is one of them, the CytoCoV-19 study that was just recently reported on the ESICM virtual conference last week by my good friend from Hamburg, Axel Neerhaus, sorry, and Axel depicted the details of the trial, which is published now on clinicaltrials.gov. And they look into patients with pneumonia due to COVID-19. And of course, these patients has to be hemodynamically unstable, moderately elevated cytokine levels, and indication the need of a extracorporeal renal replacement therapy. And the primary endpoint is shock reversal. So we'll see the studies ongoing. And we started a registry, a Cyto-8 registry, to include patients who are treated with CytoSorb after admitted to the ICU due to COVID-19 acute respiratory failure. All we want is a prospective observational study. So it is open for anyone who is willing to join. It has EC approval. It's on clinicaltrials.gov. And now we are planning to publish the pre-study protocol in trials. So in summary, there are several potential indications for CytoSorb in COVID-19 patients. There is an immense interest and activity worldwide, and the research activity is also detectable if you just punch in clinicaltrials.gov. You can see how many studies are up and going. And beyond just a few slides, what is going on beyond COVID-19 and what is novelty? Well, we have the biggest case series in a format of a registry, the CytoSorb registry. More than almost 1,000 patients were analyzed, and now we have more than 1,000 patients in the registry. And we have submitted the revised version of the first analysis of these 930 patients to critical care. So hopefully it will go through the evaluation process. And what we found was that the treatment found to be safe by the doctors. It significantly improved cardiovascular and pulmonary function. It reduced the levels of routinely measured cytokines and may have a potential benefit in the highest risk patients, and the physician satisfaction was very high, above 70% regarding the therapy. We also performed a subgroup analysis of those patients who were treated with CytoSorb for acute liver failure within this registry, and CytoSorb has two potential indications in acute liver failure. On the one hand, it protects the organism from the liver-produced cytokines. On the other hand, it can produce the liver. It can prevent the liver from the circulating cytokines. So we found very positive results. Again, the manuscript is under preparation. So well, these are preliminary conclusions. What we found that it was the third most frequent indication. It removed bilirubin effectively, and there was a very high physician satisfaction rate as depicted by that they observed improvement in the patient's condition. So this is my last slide, and there are more than 100,000 treatments worldwide. And as you can see, since August 2015, when the whole story started to be big, really, there is an immense improvement on all fronts. There are a lot of publications, a lot of ongoing studies. So you have two options, I think. And just as Professor Ronco depicted, and also Professor Mehta, that you have two options. One is you sit tight and wait for the evidence, or you can generate the evidence. And obviously, as a researcher, I do belong to the latter group. So I'd rather try to generate evidence and create data and produce studies rather than just sit and wait. So if you feel so, then please join the CytoSorb experience. Thank you very much.
Thank you. Thank you very much, Dr. Molnar, for sharing your extensive experience and reviewing the literature by showing the indications, various different indications. Coming back to COVID-19, have you been very active in use of CytoSorb therapy in COVID patients, and how did you choose your patients? If you would like to elaborate a bit.
Yes, well, I do apologize, but after September 2019, I changed tracks. So at the moment, I am not working actively on an intensive care unit, so I cannot share my personal experience with you in COVID-19 patients. However, I do direct quite a few studies on ICUs with COVID-19 patients. And all the studies and protocols we developed on this topic follow basically the same concept, that it is only indicated in those patients in whom you suspect uncontrollable hyperinflammation or vasoplegic shock. I would not, and the other indication would be acute respiratory ARDS, which reaches such severity which requires ECMO therapy. So these are my two indications. As head of ICU, I would start blood purification. So whenever a patient has refractory vasoplegic shock, or when the condition reaches such severity on the respiratory failure front, which requires ECMO.
Right. So vasoplegic shock.
We are exceeding the time. I think we should stop.
Late, and we have a request from organizers. That was an illuminating session. And if anybody has any further questions, Dr. Molnar will answer that on chat box. So thank you again from both of us. Thanks a lot.
Thanks very much.
Thank you.
So my sincere thanks to Professor Molnar, Dr. Manisha Sahai, and Dr. Prachi for a wonderful talk and discussion. And may I now ask Seema to introduce the next session.
So moving ahead, we now come to the second last session of this today's program. So we'll be having a talk on role of cytokine adsorption dialysis in sepsis management. And for the same, it's a great pleasure to invite our chairpersons, Dr. Tanmay Banerjee, sir, who's the Director, Medica Institute of Critical Care and Coordinator, Department of Internal Medicines at Medica Super Speciality Hospital, Kolkata, and Dr. Zarik Paul, sir, a Clinical Assistant Professor, Department of Nephrology and Kidney Transplant at Amrita Hospital, Kochi. So I request Dr. Paul to kindly introduce the speaker for this talk. Sir, you're muted. Dr. Paul, you're muted.
Yeah, a very good evening to all. I'd like to welcome Dr. Sawat Natachai for the next session. He's going to speak on the role of cytokine and endotoxin absorption dialyzers in sepsis management. He's presently the Director for Center of Critical Care and Nephrology at Chulalongkorn University, Thailand. May I welcome you, Dr. Sirasawat.
Thank you very much for a kind introduction. So, and thank you the organizing committee from Avatar for inviting me to sharing our experience of cytokine absorber and endotoxin absorber in sepsis patients. As you may know, in the pathway of sepsis, there are DAM and PAM that's already mentioned by many times by the previous speaker. And in that part, and that can bring into the increasing of a pro-inflammatory cytokine and also the anti-inflammatory cytokine. I would like to emphasize also the importance of the anti-inflammatory cytokine that can lead into the stage of the immunoparalysis. And right now we have many tools to measure the immunoparalysis. For example, like the decreasing of the HLA-DR expression on the monocyte, and you can use the flow cytometry to measure that. And also you can measure the chemotaxis activity by using like the modified Boyden technique. And you can also doing this test like a bedside. Recently, we have published an important role of the neutrophil chemotaxis activity in the severe sepsis patient. In the patient who survive, you will have significantly higher chemotaxis activity comparing to the non-survivor. And this emphasizes also the important role of the immunoparalysis state. Not only in the kidney, also another end organ injury that was injured by the DAM and PAMs. This is a nice figure by Dr. Pirapon Ratana in the KI 2019, and also an important role of the neutrophil chemotaxis to combat with the infection. Currently, we have many devices that can combat the infection, starting from removing the pathogen, like a bacteria or the virus. We have like an extra syrups that is one of the membrane that coated with the heparin that is a non-specific binder to viral particle. And a lot of ongoing trial of this device in Europe. We also have many devices to confront with the endotoxin and the cytokine. And one of the theory is proposed by Professor John Kellam, Dr. Si Yong Peng, and Professor Thomas Limeli from France, show that propose the cytokinetic model. If you remove the cytokine represented by the plus signal, you will enhance the activity of the leukocytes to the infected site better, and you can control the infection better. In Thailand, we have more than nearly 8 years for using the blood purification in Thailand, starting from the Osiris, followed by PMX, and also the Jaffron device, and also the endotoxin absorber by Altigo. I have experience in using the polymyxin and the Osiris that would like to share with the audience. The polymyxin is one of the device that has most widely published article coated by the polypropylene and polystyrene fiber with the polymyxin, mainly to control the endotoxin. For Osiris, mainly is the AN69 membrane coated with the polyethylene imine and heparin, and mainly can absorb endotoxin and the cytokine. Recent data in the in vitro study show by Professor Kellam groups show the activity of the Osiris that has the activity to absorb endotoxin and the cytokine in the in vitro study. We have 2 years ago we have published the randomized control trial to show the activity of the endotoxin absorber and the PMX on the moderation of the human leukocyte antigen, HLA-DR in severe sepsis patients. In this study, we randomized 60 patients into 2 groups. The patient will receive PMX with a standard treatment, and the patient will receive only a standard treatment. We follow them until day 28. And this is a demographic data. Most of our patient is gram-negative infection, and the most common site of infection is from gastrointestinal tract and the respiratory system. And this is the outcome of our study. And this is in the endotoxin absorber group, and this is a standard treatment groups. And this is the day 1 and day 3 that we measure the HLA-DR. As you can see that there are significantly improvement of HLA-DR, which means improvement of the immunoparalysis comparing to the control group. There are no any change. You have declining of the C11B. This is like another pro-inflammatory response. And you also have the improve of the chemotaxis activity after 72 hours of the treatment in the endotoxin absorber group, comparing to no significant change in the control groups. And also in terms of the mortality on day 28, we cannot show the significant difference of the mortality. However, when we look into the mortality on day 3 and day 7, there are a trend of improvement and significantly lower mortality rate compared to the control group. 20% comparing to 40%, 10% comparing to the 33%. So this treatment for me is like buying a time for the patients and waiting for effective antibiotic, effective for the damage control by the operations. And also we have doing another small study published in Journal of Critical Care to study the pharmacokinetic and dynamic of meropenem in the patient exposed to the polymyxin treatment. And in this study, we show that there are no significantly effect of polymyxin on meropenem pharmacokinetic in CVVH, and patient will receive polymyxin treatment. And interestingly, that we also have a chance to measure the endotoxin activity in COVID-19 patients. And the level of endotoxin activity, the moderate mean that you have EAA more than 0.4, and severe, which means you have EAA more than 0.6, can be up to nearly 40 and 50%. And we also comparing the endotoxin level of the COVID-19 patient to other bacterial infection. Interestingly, the level of endotoxin in severe COVID-19, the level is quite comparable to the gram-negative infection. So we propose that in the severe COVID-19 patient pneumonia, not only the viral by itself, but the viral can also interfere with the gut barrier and respiratory tract barrier and make the prominent and evidence of bacterial product. And that bacterial product may also lead to the cytokine storm. That is another pathway that we propose and is still under review. And another membrane that we have used is the Osiris membrane, which has a capacity to control endotoxin and the cytokine level. And this is a four key question for the Osiris. The Osiris is the membrane, as I mentioned, coated with the PEI that has endotoxin absorber capacity, and AN69 that have the cytokine absorptive capacity. We have published another single center cohort using the Osiris membrane and in the septic shock patient and demonstrate about the hemodynamic effect this year. And in our 35 case series, this is Apache 2 score. This is in the range of the severe Apache and high Apache 2 score, high SOFA score. And this is a site of infection. Mainly is a pulmonary and intra-abdominal infection. Mainly is a gram-negative bacterial infection. And we use the Osiris combined with the renal support. And the modality that we use is a CBVH mainly. And this is a setting that we use. At that time, we do not use much citrate anticoagulant. And this is a hemodynamic outcome of the patient after Osiris treatment. There are significantly improvement of inotropic score, vasopressor dependency index, and norepinephrine dosage. And this is a hemodynamic parameter, significant lowering after 72 hours. And this is our case study comparing to the previous study. And most of the study show in the same pattern, improvement of cardiovascular SOFA score, norepinephrine dose, and increased mean arterial pressure. So which setting that we should apply the Osiris? And this is my point of view that we may use that guided by like a sepsis biomarker. If you can measure the endotoxin, or if you can measure the cytokine like IL-6, and this is my proposed cut point. Or if you can measure HLA-DR by flow cytometry, this is another way that you can think about to use the endotoxin or cytokine absorber. Or you can use like hemotaxis activity that I mentioned. Or if you do not have any sepsis biomarker, I think it's still worth to use like a clinical parameters, including high dose vasopressor setting, or some setting that have a high endotoxin activity, like abdominal infection, high cytokine level, like a setting of severe pneumonia. From my point of view, the Osiris can support even in the sepsis alone, because we clearly show the improvement of HLA-DR and also can do the hemodynamic support by improving cardiovascular SOFA score. Can be the AKI support because they combine with the CRRT membrane, and also can use for the patient who have sepsis and AKI because they can cooperate also sepsis support, renal support, and hemodynamic support in the same time. We should start as Osiris early as possible, and also you can start because the endotoxin quite play a role during the early phase of the sepsis, or even in some of the late phase, and the cytokine level may increase. You can also apply the the Osiris. And this is our protocol to use the Osiris. We still prefer to use the citrate, even you have the heparin coating, because there are some randomized study from Singapore show no improve of the filter lifetime, even you heparin coated in the Osiris. We still recommend the standard dose. We still recommend to, but we still don't know when, how often that we should change the filter. The duration, I think we should start until the clinical improvement, like no any longer of a vasopressor. And also, if you can measure the biomarker, that might be another way to prescribe the Osiris. In summary, I think the extracorporeal purification, they have the triple effect, but there are still challenging questions like patient selection, initiate timing, protocol when we should change the filter, and also the issue of any antibiotics, micronutrient that may remove or absorb by the filter. Finally, I think we should follow the Hippocratic maxim, do the benefit and do no harm to our patients. So we need to balance the safety of the patient with the benefit of the treatment. And finally, I would like to invite all of the Indian doctors, nephrologists and intensivists to join our 4th Asia Pacific AKI CRRT that will be hosted in Bangkok, Thailand at the end of this year. And this is the hybrid format. We have both of the on-site and a virtual meeting. We have like more than 30 international leaders in the field of critical care nephrology to join us in our meeting. Thank you very much for your thank you very much for your attending.
Dr. Banerjee, please conduct the discussion.
Yeah, thank you, Dr. Natachai, for your kind and very excellent presentation. I think obviously we all have been sort of using extracorporeal therapies for sepsis, and in COVID also we have tried in few cases where they're very sick. But my thing is that, you know, I mean, coming back to our previous discussion and also this session as well, I mean, the topic is actually the most important point is to select the patients early, and you know, any form of extracorporeal therapies or any other interventions would work when selected early. And in our experience, sometimes we have seen that we have waited till the severity or renal support is needed, and then to start extracorporeal therapies along with CRRT or any renal support, as well as other extracorporeal supports like ECO or ECMO. So obviously, if we discuss that, you know, if there is any way to select our patients early, so we know that this patient probably is going to benefit, apart from whatever we have got, the markers for lactate, for vasopressors, for, you know, I mean, SOFA scores and other obviously parameters. So there is no magic biomarker we know as of now, even in sepsis or COVID, but we are able to measure only IL-6 at the moment, and that also takes 6 to 8 hours or even 24 hours to turn over for the reports. So if any sort of other clinical criteria, obviously we have been using, but if any thoughts regarding when we can consider to start early.
Yes, thank you, Professor Banerjee. In the COVID-19 patient, we also have some experience to apply the cytokine absorber. And in that case, we apply the treatment even before the kidney failure. So we use the device at the time of the declining of the respiratory function, like a PF ratio less than 300, and to use them to try to stop the macrophage activating syndrome or the cytokine storm. And also we observe that in those kind of the patient, we cannot avoid intubation, but we can reduce the time of the intubation in many of the patients. So I think even the clinical parameters still very important. And I totally agree that we should apply this kind of the treatment even sometime before the organ failure. But the problem is we need to balance between avoid to use this device in the patient who do not need that. And we should apply that in the patient who only need that. And that's also another challenges question. Like when we perform the CRRT, in the early or delay stand treatment, like the issue of the timing. I think the issue of timing for extracorporeal blood purification still be the same.
Thank you.
Thank you.
That,
Yeah.
obviously, that is probably something to debate, and obviously the answer is that any therapy probably would work early if started, but we don't know how early to start and how to select our patients exactly. Till they deteriorate. I mean, I've been impressed by what Dr. Natachai said, that to start on extracorporeal therapies even before they have been on ventilator. But in practice, we have been using it maybe when the patient is on ventilator in mitral valve failure with renal failure and septic shock, or sort of on vasopressors already. So this group of patients, we know the mortality is nearly sort of 50% to 70% already. So trying to salvage the last moment. Obviously, sort of last ditch effort to salvage our patients. But if we could sort of have a consensus about how we can select those patients early, would be sort of usually greatly beneficial for our practice and for our patients.
Dr. Banerjee, for want of time, I think we should close this discussion, and whatever questions are there, we can have it on the chat box.
Sure.
Because we are already exceeding by 15 to 20 minutes.
I know it's already 8 o'clock. Thank you very much.
Yeah, yeah.
Thank you. Thanks.
Thank you so much, Dr. Sesawat and Dr. Banerjee and Dr. Zakaria, for a wonderful session. And back to Seema for the next session and introduce the speakers.
Moving ahead in the last topic of the day, we have the topic of ECMO for the nephrologists, and it's with greatest pleasure we welcome our respected chairpersons, Dr. Rajesh Chavla, sir, who is a senior consultant, Institute of Critical Care, Respiratory and Sleep Medicine at Indraprastha Apollo Hospital, New Delhi, and Dr. D. Mukherjee, sir, Chairman and Head Department of Renal Sciences and Renal Transplant, Batra Hospital and Medical Research Center. So I request Dr. Rajesh, sir, to kindly introduce the speaker for this session.
Good evening. Thank you very much. And, for the last about 10 years after the H1N1, the ECMO has gained a lot of importance in the use of critical care. Not only now in this refractory hypoxemia, we are finding new indications for use of ECMO. So today we are going to discuss the ECMO for nephrologists. Many a times when ECMO is there, then when you require dialysis, the question comes where to attach. And all these issues will be addressed by Dr. Vivek Gupta, who is a consultant cardiac anesthesia and intensive care coordinator ECMO program, Dayanand Medical College and Hospital. Dr. Vivek Gupta is one of the persons who had used ECMO in the LFOS poisoning, and he's got a very large series of use of ECMO in LFOS, and he saved many patients. So over to Dr. Vivek.
Thank you, sir. Thanks a lot for the kind introduction. So I'm just trying to stick to the basics so that it is understandable to all of us, especially our nephrologist colleague. So whenever we talk about ECMO, it is basically a modality which is used for the refractory cardiorespiratory or respiratory failure when conventional treatment is not useful. So, as Dr. Chavla said rightly, that in last 10 years, we have learned much about the ECMO, and this modality is being regularly used in the intensive care unit. But the foundation was laid down actually in 1950 when John Gibbon initiated the cardiopulmonary bypass. Then there was a period of almost 20 years in the early 70s. This was first used in pediatric patients, especially for those shock lung syndrome,
it was used successfully. But due to a study by National Institute of Heart, America, where they showed a mortality of 90% in a patient of ECMO who were treated of ARDS who were treated with the VA ECMO. Actually, there was a big flaw in the study, which we know now that for ARDS, we don't need a VA ECMO. Actually, we need a VV ECMO. But this was a big setback to the ECMO program. And for next 30 years, it was restricted only to the few centers and especially for the pediatric and neonatal population. But since 2009, actually, we have learned a lot and we are looking for the various indication to do ECMO for these patients. If you look at the global data as with the ELSO, Extracorporeal Life Support Organization, which is an organization that collects the data across the world, almost 130,000 cases have been done so far with a survival of nearly 55%, which is the survival is much higher in the neonatal population, especially for the respiratory ECMO, and relatively lower VA ECMO in all groups of the neonatal, pediatric, or adult population. And these are the numbers of centers and runs gradually increasing year by year as we are learning more doing the safe ECMOs. We are able to increase the numbers. So whenever we talk about ECMO, it's not an individual job. Basically, we need a big team for ECMO. And it's a big teamwork where there should be a good coordination. So especially, it's basically under the run of ECMO specialists. There should be anesthesiologist or cardiac anesthesiologist, and input from the critical care specialist because it's multidisciplinary care. And a surgeon is required, especially when we need a cardiovascular vascular access for this. Besides this, other specialists, especially the nephrologists, come in the picture because in so many cases we come across with acute kidney injury when where we are performing the ECMO. Besides this, perfusionist, who is the core for this, critical care nurse who should be trained in the perfusion, and other specialty, including the medical social worker and psychologist, especially to deal with the patient as well as the patient family, is a very important member of the team. So my talk will be basically focused briefly on the ECMO itself, for the physiology, type, indications, monitoring, and complication, how nephrologists are involved so much with the ECMO, and some technical consideration, how these can be integrated, especially in cases of CRRT. So as I said, it's basically extracorporeal life support where a circuit which is carrying a blood from the patient, so we call it as a venous end, then gas is exchanged in a device which is called as oxygenator, where the carbon dioxide is removed and oxygen is pushed in, and then blood is returned back either through a central vein or a major artery. And that decides that whether it's a VV ECMO, it is passing through a vein, or VA ECMO when it is passing through an artery. So the question always comes because for two reasons. One, it's pretty costly. And second, more important, it has a lot of complication when we look at the literature. So do we really need it? When we have so many advanced ventilation technology in the techniques in the intensive care unit, we have so many drugs to maintain the hemodynamics. So to answer this question, actually, we need to understand why these patient dies. Because when we start increasing our ventilatory parameters, and these patients are aseptic patients, are patients in the shock, they develop multi-organ failure. Because as we increase the PEEP or we increase the ventilatory setting, it leads to not only ventilator-induced lung injury, not only the barotrauma, but the volute trauma and epileptotrauma and toxicity of oxygen as well. Besides this, when we put a high ventilatory settings, it always has some cardiovascular effect, decreasing the venous return and decreasing cardiac output and altering the hemodynamics. Then we keep pushing the fluid, we increase the fluid, fluid overload, and ultimately organs, they compromises with the organ edema. Patient in due course develop the secondary sepsis. There is always a worsening of global or regional tissue perfusion. And as second organ gets involved in the shock state, the mortality increases by 10%. So what it does basically, it supports the cardiorespiratory system, provides oxygenation, we try to maintain the mean arterial pressure by maintaining the cardiac output, and thus maintains the tissue perfusion. So basically it's a bridge, which can be a bridge to recovery when we say that's a reversible cardiorespiratory or respiratory failure, or it can be a bridge to a mechanical assist device, or if the organs are completely failed, it can be used as a bridge to heart, lung, or both heart lung and lung transplant. So it should be very clear that when exactly we want to do that. The first dictum is condition has to be reversible and patient should be unresponsive to the conventional therapy, and when we feel that the mortality risk is very high if not treated aggressively. So basically we give rest to the organ like the heart or lung. So as I said, the type of ECMO, it can be a VA ECMO or VV ECMO, and there can be some variant of ECMOs as a AV ECMO when we just want to remove the extracorporeal carbon dioxide. So this is the diagram which is showing a VA ECMO. You can see the blood is taking from the femoral vein, it is passing through a pump and then oxygenator, and finally it is going back through the femoral artery. So basically it is supporting both heart and lung. This is for respiratory support. You can see the blood is taken from the femoral vein, passing through a centrifugal pump oxygenator and going back to again to the major vein, that's an internal jugular vein, and is reaching to the superior vena cava. So basically oxygenated blood is being pushed in the right side of the heart. So this is the patient who is having who is on VV ECMO. You can see this is the femoral axis we have taken, and this is the return cannula for the VV ECMO. And this is a patient where we have done the femoral veno-arterial ECMO, and there is a this is the distal perfusion. You can see that to maintain the distal limb perfusion, because this is the thick bore cannula of 17 French which we have put in the femoral artery. So this is the most common form of doing a VA ECMO through the femoral axis. It can be done either percutaneously, or we can use the semi-Seldinger's or Seldinger's technique, which is done by the cardiac surgeon. The other sides is also used like axillary subclavian, or sometime in neonate we do use carotid artery. So this is how whole system looks like. You can see this side is the patient, and blood is coming through the venous line, and it is going through the pump. Then it is pushed to the oxygenator, where you can see this is for the temperature regulation. And then and this green tubing, you can see this is basically a oxygen flow, which helps in the gas exchange, and we can adjust the oxygen percentage, that what FiO2 we want to give. And once the blood is oxygenated, it is pushed back to the patient, depending on in the arteries or vein, we can say it's a VA or VV ECMO. So if you look at the indication for VA ECMO, basically any acute myocardial infarction and patient is in the cardiogenic shock, not responding to the conventional therapy. Any fulminant myocarditis, whether it's a toxic or viral myocarditis, or there are cardiac failure due to the intractable arrhythmia, patient is unresponsive to the medical management in that situation, or post-cardiotomy, supporting the heart for the post-cardiac surgical patient. For VV ECMO, any acute respiratory distress syndrome, whether it's because of viral, bacterial pneumonia, or there is a graft dysfunction after the lung transplant, pulmonary embolism, that's a unique feature. If it is only an oxygenation problem, it's a VV ECMO. But suppose there is a massive pulmonary embolism and patient is having a cardiovascular collapse, and you are doing a CPR, or patient is needing CPR, then a VA ECMO is indicated. Besides this, if a patient is having a severe bronchospasm and not responding, then probably just for tiding the crisis, you can do it, a VV ECMO. But there are certain contraindications. We should ensure that all contraindications have been ruled out before doing ECMO, especially where we don't expect a recovery, or there is an unwitnessed cardiac arrest and we have done the prolonged CPR without adequate perfusion, or there is aortic dissection, or there is some irreversible neurological condition. Relative contraindication includes some issues related with the contraindication of anticoagulation, or there is a compliance issues for the patient. It is very important because you are dealing with the machine, we are integrating machine with the patient. So monitoring is very important, and probably that's the most important aspect in the ECMO management. Besides routine vital parameters, especially for VA ECMO, we need a right hand saturation, or if you can put a radial artery in that right arm, right radial artery, this is very vital to monitor because it gives the idea about the coronary and cerebral perfusion. And for a VA ECMO, we look for the mean arterial pressure and pulse pressure to ensure the adequate cardiac functions and adequate perfusion. We keep checking the blood gases, and we look for the mixed venous and lactate levels. For a VV ECMO, we focus on the oxygenation and carbon dioxide removal. Besides this, routine echocardiography and urine output is very important. We look at the hematological parameter. We try because blood is coming through the foreign circuit. So in those situations, plasma-free hemoglobin has to be monitored, and blood gases, patient's vascular status, that there's no bleeding, or neurological status, urine color and quantity both has to be monitored. Coagulation parameter, we try to initiate, when we initiate ECMO, we try to keep activated clotting time around 300, but normally during the maintenance, we keep 160 to 180 seconds. We keep checking it every 6 to 8 hours. And once in 24 hours, we look at the APTT, which should be maintained between 60 to 70. Monitoring of ECMO system is probably very, very important to ensure that it is working accurately, it is having adequate efficacy, and it is safe for the patient as well. To look at the accuracy, basically we look at the blood flow rate, we look at the sweep gas flow rate, we measure the, we monitor the revolution per minute, because that tells us about the how much is the vascular resistance in the VA ECMO and how much is required to maintain the adequate oxygenation in. That gives an idea about the respiratory lung functions. And we keep monitoring the membrane function, because that's a vital for gas exchange. To looking at efficacy on during VA ECMO, we look at the mean arterial pressure and pulse pressure to ensure that adequate perfusion is there and there is no LV distension or there is no myocardial stunning. On VV ECMO, we look at the PaO2 and PCO2 level, and tissue perfusion is monitored by looking at the mixed venous saturation or venous saturation and lactate level. To ensure the safety, we always check at least once in 24 hours about the circuit integrity for clot, leak, or any noise in the pump. We monitor the pre and post oxidative pressures and other coagulation status. We keep checking the echocardiography and some biochemical parameters to ensure that the system is safe for the patient. So coming on the complication, why it is important for the nephrologist. This is very, very important because the incidence of complication with the acute kidney injury in the patients who are on ECMO is around 60%. And it is as high as 80 to 85% in certain class of the patient, especially post-cardiac surgical patients, or who are having a cardiovascular collapse and requiring VA. And almost half of these patients may require a renal replacement therapy. So why it is important? How? What are the things which leads to these all AKI? So basically, if we look at the pre-treatment factor, if these patients are critically hemodynamically unstable, they have the hypoperfusion, they are having the low cardiac output state, are those patients who are having ARDS, having hypoxia, they are probably having infection or at least systemic inflammation, and they are on the nephrotoxic drug, and to maintain the hemodynamics, they are giving a lot of fluid. And these all actually contribute to development of acute kidney injury even before initiation of the ECMO. Then during ECMO itself, it's a very complex situation. On one side, we initiate the ECMO, we improve the tissue perfusion, and in VA ECMO, we improve the cardiac output. On the other hand, the ECMO-related issues itself induce the kidney injury because ECMO in the initial phases induces a lot of systemic inflammation. Because of that, there is the shear stress of the blood, and blood is coming with the air interface, and these all leads to systemic inflammation and induce the kidney injury. Besides this, because blood is coming in contact of the foreign circuit, there can be embolism, there can be hemolysis, and there can be hypermyoglobinaemia. So all these factors, cardiorenal syndrome, lung renal interaction, these all contribute to the development of acute kidney injury. And as we see, the rightful stage, the onset of ECMO is associated with a significant increase in mortality. So every goes by a few percent more. So how to investigate these acute kidney injury in these patients? We all know that physiological parameters like looking at the blood pressures, cardiac output, urine output, renal blood flow, these all gives an idea that how the kidney is functioning. Routine biochemical parameters gives us an idea to diagnose acute kidney injury, but along with that, it is very important that we look at the plasma free hemoglobin, we look at the hepatoglobin to identify whether acute kidney injury is actually associated with the disease process or there is a it is associated with the circuit itself. So this differentiation is very, very important because that will decide that how much should be the blood flow, or probably there is some issues with the pump and you need to change the pump head. So these things are very important. You quickly identify that whether it is the hemolysis or it is actually a problem associated with the disease itself. Imaging is always helpful, But yes, histopathological and immunohistochemical analysis is possibly, it is not possible. Biomarkers so far do not have much role in the early assessment, because we need some more studies and more evidence for this. So what are the options? Options can be either continuous or it can be intermittent. Or continuous, it can be CRRT or it can be peritoneal dialysis. Or in the intermittent therapy, we can have the ISD or split. But all have its own benefit or its own complication. If you look at the intermittent hemodialysis, it reduces, it basically can be connected through the ECMO circuit itself. It's a not a costly affair, but rapid fluid removal in such a hemodynamically unstable patient probably can be detrimental. And same true for SLED also, though we are doing it so slower. CRRT that we has an edge over this because it can be prolonged and so many things, metabolic controls and hemodynamic controls can be managed. Though there is always, it is said that patient is immobilized, but patient on ECMO itself is already immobilized. So there is no issue about it. Similarly, hypothermia is another problem with the CRRT, but temperature regulation or cost is always managed on ECMO. So that is again not a big issue. Cost, when you are doing such a costly procedure of ECMO, the cost of CRRT is not too high. Peritoneal dialysis is mostly restricted to the pediatric population, but you should always keep in mind the risk of peritonitis is always there. And because the abdomen is full, so it pushes the diaphragm up and it can delay the weaning from the VV ECMO itself. So how to do it and when to do it, probably that is very, very important. So far, no one knows that what is the right time, but it has been shown that preventing fluid overload is associated with the better outcome. So early CRRTs should be done. The main indication is fluid overload and prevention of the fluid overload. Besides this, metabolic derangement and electrolyte disturbances should always be as an indication. How to do it? It can be done is a separate circuit, that because there is one ECMO circuit is going on, you can just do another cannulation and you can do a CRRT. You can do an inline hemofiltration filter, it can be applied, or CRRT and ECMO circuit can be integrated together. All these have its own benefit and its own complication. When we do it through a separate circuit, there is no problem. We can do it, but the only disadvantage, because patient is on heparin, so there may be a risk of bleeding, and multiple, because sometime on ECMO we need more than one access, so we are losing one access. Otherwise, both systems do not interfere with each other. When we talk about the inline filter during the ECMO, this is basically attaching a filter. Those who are from the perfusion side, they know it very well that how to connect it. The advantage, it's pretty cheap, but the disadvantage, you don't have much of the control. So all the therapy, CVVSD, CVVSDF, or CVVH can be done using the hemofilter. You need to just add the dialysate or replacement solution through the infusion pump. But the only problem is the accuracy may be compromised by using these methods. They are the cheaper one, and in certain situations, you can definitely use it. The third, integrating CRT machine in the ECMO circuit itself is
Dr. Vivek.
Yeah, in 2 minutes, just 2 minutes, 2 more minutes.
Yeah.
Okay. So integrating CRT device with the ECMO machine itself can be a useful method, but as a nephrologist, you must remember that there are certain pressures, certain things you need to keep in mind. If I look on this diagram, from here to here, there is always a negative pressure. Beyond this centrifugal pump, there is always a positive pressure, and anything going beyond the oxygenator will directly go to the patient. So this is very important. This pressure is negative, so you will always get a negative pressure alarm on this side. This is the positive pressure, so you will get, if you are connecting a return line on this, then you will always get a positive pressure alarm on this side. So you should know that how to override these alarm and how to operate these machines, but never try to attach any circuit beyond the oxygenator, because anything, any air or any clot will go directly to the patient by using these methods. So one has to be careful about the blood flow rate, especially during the VV ECMO, because even a small change of the blood flow can decrease the oxygen saturation of the patient. You don't need any additional anticoagulation during this additional of CRRT, but there is always risk of embolization, so that this can decrease the life of oxygenator. One has to be careful about the alarm. there is more risk of hemolysis because you are adding 2 circuit, and antibiotic dose needs to be increased because again you are using a CRRT along with the ECMO. So to conclude, basically ECMO is an advanced form where we can support temporarily for the cardiac or cardiorespiratory system when the patient is not responding to the conventional therapy. With the expanding potential indication and improving outcome, we are looking for the more and more application of ECMO. And these patients require a multidisciplinary specialist because acute kidney injury is a very common complication, especially in a patient who are on ECMO. And this is very important to differentiate that whether it's a disease related or there is a problem associated with the circuit. And we should be aware of the challenges when we are integrating 2 circuits together. Thank you very much for your attention. I'll be happy to answer any question.
Yes, Dr. Mukherjee.
Thank you, Dr. Vivek. That was a lovely talk, and I at least have become much wiser regarding the use of ECMO and the different types of ECMO. Very interestingly, some nephrologists, even in India, have used ECMO to maintain the renal, kidney, which has been harvested after disease donation after cardiac death. In fact, PGI Chandigarh is one of those institutions that have done it. Do you have any comment on that?
No, I don't have any experience, so I cannot comment on this.
Okay, but what your talk has really brought forward one point, that management of conditions today actually blurs clinical lines and involves multidisciplinary approach. I got interested in ECMO after hearing the experience of PGI Chandigarh in maintaining the organs. But obviously, your experience is more towards treatment of cardiac cases and multi-system organ failure cases.
Not only that, respiratory system as well, but not for the organ, sir.
Okay. Are there any questions from the audience or from my co-chair, please? I think, how much, what would be the approximate cost of maintaining a person on ECMO per day?
So basically it's a initiation cost only. Otherwise maintenance cost is not a high cost. It is usually same as for the ICU cost. But yes, initiation cost is roughly around 4 lakh to 4.5 lakh. Because if you are using a cannula and you are using a circuit, so all these makes around 4 to 4.5 lakh to initiate them.
How has been your experience with the recovery of patients who have been put on ECMO?
Sir, for the VECMO, especially for the aluminum phosphate poisoning, our survival is nearly 70%. And for a patient who are ARDS, post-viral ARDS or other ARDS, the survival is around 55%. With the ECMO CPR, fortunately, we did ECMO CPR in 4 patients and 2 has gone home, 50%.
That's very interesting. If there are no other questions, either from the audience or from my co-chair, I will thank you very much, Dr. Vivek, for such a lovely talk and educating us on this complex therapy. There seems to be Dr. Ramesh Jain has a question. Just a moment, please.
Yes.
There seems to be a question. Let me see, I can get it. The question is, what is the indication of starting ECMO in a COVID-related type 1 respiratory failure?
Great. It is as same as any other patient who is not responding to our ventilatory management. In those cases, like a ARDS patient, but one has to be very careful, and especially in COVID patient, because there is a more risk of pulmonary fibrosis in these patients. So later it can be a candidate for lung transplant as well. So we have done in 3 cases. And what is our suggestion and which has helped us, early institution, when you are initiated the ventilation, and once you have initiated and patient is not maintaining, as early as possible, because normally it is said up to 7 days with the high ventilatory settings, you can go for a ECMO. But for those patients who are who are post-COVID are developing ARDS and not maintaining saturation, it is better to go early so that their survival is definitely better.
So Dr. Vivek, you go in for standard ventilation followed by prone ventilation and then by ECMO, or you go straight away?
No, sir. We go for first, if he's maintaining with the standard ventilation, there's no problem. But if we are needing a higher PEEP, we need airway pressures are not maintained, it is going beyond, then only we go for ECMO. Even we try proning as early as possible. We go for proning, we do everything. If it is not responding, we go probably by second day or third day for ECMO as early as possible.
Okay.
You know,
Dr. Vivek, thank you once more.
Problem
And
with the,
so,
yeah, problem with the COVID is that, you know, most of the time it is started late. And whatever we are seeing, these patients have fibrosis. And you need to, I mean, this is a disease which is going to promote lung transplant quite a bit. And a lot of patients are being shifted to centers where the lung transplant is being done. And like Vivek said, unless you start early, if you start late, then you're stuck with fibrosis, and weaning off is a great problem.
True, sir. Very true.
Thank you, sir.
Thank you, Vivek. Thank you very much.
Thank you, sir. Excellent.
So we wind up this session. Thank you.
I thank Dr. Vivek Gupta, Dr. Banerjee, Dr. Mukherjee, and Dr. Chawla for a wonderful session. And Vivek, it had been really a feast of your excellence, and we learned a lot from you, because we as nephrologists, we are not doing this kind of therapies, and it was a great learning.
Thank you, sir.
And
Thanks, sir.
you will all agree with me that we had a feast of academic excellence. Professor Molnar discussed about the discovery of stress, dysregulated cytokine production, role of medium to high levels of pro and anti-inflammatory lymphocytokines with increased hazard ratio for death, and role of early intervention in improving the survival. Dr. Ronco discussed upon sequential extracorporeal therapy, role of high flux and medium cutoff dialyzers with high sieving coefficient. Dr. Yatin Mehta discussed about cytosorb, its indication, how long to continue and when to abandon the procedure, and also talked about that not only it removes cytokines, but other things like bilirubin, myoglobin, and free hemoglobin, which are toxic for the kidney. And Professor Molnar shared his experience on cytosorb in animal experiments as well as clinical experiments. And Dr. Sri Sawat discussed about role of polymyxin, its beneficial effects in improving the morbidity and mortality, and role of oxalis, which not only removes cytokines and endotoxins. And he has discussed for the first time in this symposium that there are certain clinical indications and some lab indications like toxin levels more than 0.6 and IL-6 more than 500. And finally, I thank Dr. Vivek Gupta for a very, very lucid talk on ECMO. And with this, I will thank all the speakers, the chairpersons, and all the participants in this webinar for their excellent talks and excellent discussion. Thank you so much. And there is an announcement for tomorrow, which is a session on newer pharmacological interventions and changing practice patterns, which will be the last session of this Avatar web conference, and which will start at 5:30 p.m. tomorrow. And General P.P. Verma will be the convener for this symposium. And I invite all of you to join the webinar tomorrow sharp at 5:30 p.m. Thank you all. Thank you very much. And I'll now hand over the mic to Seema for the final remarks.
Thank you so much, sir. for wonderfully concluding the session for today's program. And with this, we will see you all tomorrow at 5:30 for the contemporary nephrology issues. Thank you so much.
With the aim of life longevity, the growth of medical science and change in its technical expertise in every sphere is phenomenal. To cope up with these changes, it's prudent for existing physicians and technical staff to enhance the skills of human intervention from time to time.